If I could kindly ask people to start taking their seats so we can get started. Yeah, it's gotta be like David Livingston. Yep. All right, again, if people could start grabbing their seats, there's plenty of seating for those that are standing in the back. Please do be comfortable. It's going to be a wonderful and lengthy program, and we'd like to get started in the interest of time because we have a lot to get through. I think all of you have your agendas in your booklets when you've registered, and we expect many more people to be coming in throughout the course of the day. Let me begin by obviously extending a very warm welcome and thank you to all of you that are here, certainly to our partners at Westchester Community College and we at WMC Health really take a significant amount of pride in not only being here today, but how being here today is emblematic of what all of us do together. We do recognize that trauma is a field that is not about an individual or even an institution. It's about the patients that we serve, and it's certainly about the multitude of different disciplines and providers that really come together to take care of each individual patient. And we certainly recognize that many of you in the audience really are on the front lines of trauma care, and we appreciate the work that you do, and we're privileged to call you our partners. So with that, I'm going to turn it over to my colleagues here, Dr. Tina Kakuza, our Medical Director of Logistics, the Transfer Center, and EMS Coordination, and Mark Musicus, our Injury Prevention Coordinator and EMS Coordinator as well, and we'll get the program started. Thank you again, and please do make yourselves comfortable.
All right, so thanks everyone. For those of you that don't know me, I'm Tina Kakuza. Amongst many other things, I am the EMS Network Medical Director. And we want to extend a warm welcome to everyone, especially all of our EMS providers. We have a pretty exciting day for you today. The morning will be a little bit more low-key and kind of free flow with the workshops, and I'll explain how those are going to go. And then the afternoon, Dr. Prabhakaran and the Trauma Symposium will have some exciting keynote speakers. So, these CMAs all started as very small in a classroom with me and like 10 of you guys, and they've really evolved into much larger scale events where you don't have to listen to me talk for 2 hours, which I'm sure you're all very excited about. WMC Health is now fully integrated with EMS, CME, audits, across the network. We delivered over 450 hours of CME to EMS in 2023, including 8 in-person symposia such as this one. This obviously is going to be the largest of the year. Our mission is to serve regional EMS in order to bring the latest EMS education to you almost every other week throughout the year. The panel of experts we provide, as shown by our esteemed colleagues here today, across trauma, peds, neuro, burn, cardiac, emergency medicine, and many others. Additionally, our commitment to QA, QI, and PI and loop closure with EMS is a top provider. We really see you as patient care partners in the continuum of our care, not just people that drop patients off and go. We hope every time you bring a patient into any of our facilities across our network, you feel welcome. Just very quickly for the agenda, the workshops are going to start off in the beginning. Mark's going to go over a couple of small logistics. For the workshops, anyone who is in the first 8 rows, stay here. 7 back rows, come on back with me. After we have a warm welcome from Dean Contreras and one of our chair of the Board of Trustees here for WMC, and we will direct you where to go. In the workshops, we will be doing a trauma simulation here. We will be doing needle decompression and splinting over in the back. And I will keep my crike session open throughout the day, so anyone who wants to practice cricothyrotomies, in the past we haven't had enough time for everyone to get to do it. So anytime you want to come see me, grab me and we can go over that. That being said, I'm going to turn it back over for the welcome.
Thank you, Dr. Kakuza. Just to reiterate, Dr. Prabhakaran and Dr. Kakuza, we thank you all so much for being here today. Today is really going to be a great day of trauma education, and we could not do it with all your help and support. So thank you all for coming. As Dr. Kakuza said, when we do the breakouts, which are going to happen just at about 10:40, the first 8 rows stay here for the trauma simulation, and then the back 7 or 8 rows, you're going to be going to the workshop stations. That's going to be right past where the breakfast area was. If we have to egress, you're going to be able to go out the back door, same way that you came in, and just exit right through the parking lot, okay? Bathrooms are going to be off to the right-hand side, both male and female, so please feel free to use them. And as Dr. Kakuza said, the morning part of this is sort of free flow, and the agendas, of course, on the outside. Now it's really my pleasure to introduce one of the co-hosts and the dean of the School of Allied Health and Sciences here at SUNY Westchester. George Contreras is not just the dean, he is a medic, he is a nurse, and he's been a mentor of mine for almost 18 years. We actually started together. So without further ado, I'm going to turn it over to George. George Contreras, Dean of SUNY Westchester.
Good morning, everybody. How's everybody doing today? Nice. I like the energy. So again, as has been said, I'm a paramedic, still work in New York City as a paramedic, and I recently became a nurse, so I'm excited about my new chapter in my life. But I really think that these types of events are so important for us. Why? For all my EMS providers out there, EMTs and paramedics, first of all, I want to thank you all for doing what you do, especially if you're doing it as a volunteer. I think that's wonderful that you contribute back to your communities. I still volunteer up in where I live in Orange County, but I think it's a huge testament to the work and motivation that we have. Why is this great? I think these activities are great because you all know that we rarely get to hear at the level of trauma what happens once we drop off the patients in the hospital, much less get to see our patients once they have recovered. I find this is the second time that we hosted here. It's just an amazing opportunity to see those stories and hear those stories of those survivors. So I welcome you. I hope you have a great day, and I'll be around. I'm happy to talk more about EMS and nursing, and all my nurses in the room. Please tell me where to go, because I'm just starting this chapter in my life. I want to take a moment to introduce our Provost and Vice President of Academic Affairs, Dr. Morris, who will be giving you welcoming remarks on behalf of President Miles, who will not be here today because she's off-site. Thank you very much.
Good morning, everybody. It's great to see you all here. I'm guessing that on a hot day like this, this is a day that keeps people in the medical industry quite busy with all the heat. So thank you so much for joining us. I do want to thank Dean Contreras for his leadership in working with WMC Health to use this space for your event, which looks like it will be a very busy and intense day. I have to say that when the opening remarks already go over my head with technical terms, that's probably a good sign of the learning that I think will take place here today. So as you know, Westchester Community College is deeply committed to the health field. We graduate hundreds of students each year into the health fields, including paramedic, radiologic technology, respiratory technology, nursing, and CNA. We're very proud of that and proud of the role that we are able to play in the community in terms of training. And that, I think, aligns beautifully with this event today. I'm hoping that there's maybe a few WCC alumni among you getting further training here. So with that, I'm just going to welcome you. Thank you, WMC Health, for your partnership. And I hope you have a great and productive day. So welcome.
Thank you, Madam Provost. Again, today will be about education. We will hear some lectures. We will honor some of our own region's providers for their work here in Westchester County, the Hudson Valley, and beyond internationally. And the crown jewel of this event over the last several years has always been about the patients. The survivors of trauma that we together in this room collectively have cared for, that have been gracious enough to return with their families and share their stories of fortitude, strength, and rehabilitation and that's towards the end of the program, and I think that's a great icing on the cake. But to signify the importance of this event for the community, for the region, and certainly for WMC Health, it's really my significant honor to introduce Mr. Zubin Shroff, the chair of our board of directors for our 10 hospital network at WMC Health. Mr. Shroff, thank you for joining us.
So Dr. Prabharakan's kind. He's thanking me. Honestly, it's a privilege. I've been a almost 50-year resident in the Hudson Valley, and on behalf of not only the board of WMC Health, but really the Hudson Valley community, I want to thank you for your service. We know how important trauma services are to the region. I've grown up in the area. My father was a New York Medical College alum, and he hammered into me that WMC Health is the only level 1 trauma center really in the region, and that if anything happened to my children, I was to take them, not try to get to the city, but to take them to that location. Of course, it's you folks who are always on the scene first. We know that your job is a very difficult one. We know that in a post-COVID environment, whether they're weekend warriors getting out or accidents, they're all on the rise. We know that those volumes are on the rise, and of course, then there are events like the Middleton bus accident where we see it on TV in the news cycle every few minutes. So once again, thank you for your endeavors, and know that you have a partner that's committed to supporting you. You know, obviously we maintain the Valhalla Level 1 Trauma Center designation. We've got Maria Ferrari, we've got Bon Secours in Suffern, we've got Health Alliance in Kingston, and then we have Mid-Hudson now in the Poughkeepsie area. So we're committed to continuing to expand our network capabilities. What I can tell you is that we understand the multidisciplinary nature of this. We understand that you can't build these types of capabilities overnight, that they take great coordination, training, and investment in technology. And we maintain our commitment to that as well. We've continued to invest heavily in telehealth technologies that hopefully assist you in the field and where the patient is. We've built hybrid ORs to take care of the patients. We've put in place navigation services and caregiver centers for families who had no idea that they might be showing up at the hospital. And we're committed to continuing the extraordinary growth of services that have happened, particularly over the last quarter century, for the next century. And so as AI is deployed and can help make life-saving decisions faster, more efficient, we will invest there too. So right now, I just wanted to welcome you and thank you for your partnership.
Thank you, Mr. Shroff, for your words of welcome, for your presence here today, and certainly your leadership and vision for WMC Health. With that, we're going to go ahead and get started with the initial part of our program, which is workshop-oriented, prior to lunch, at which time we will then begin more of the presentation format with our distinguished visiting professors and some of our own faculty that will be delivering lectures. So for now, we'll follow the guidance of Dr. Kakuza, where the first 8 rows will stay in this room for a trauma simulation, and those that are in the rows behind that will move on to the workshops that have designated locations, and then everybody will get a chance to partake in all of those, and then we'll reconvene here. So thank you again. Remember that there are bathrooms right off to the side. There's breakfast outside. There'll be lunch served as well. There is Wi-Fi access, and the instructions for Wi-Fi and for claiming your continuing education credits are all contained in the same folder that contains the agenda. So welcome again, and with that, we'll go ahead and get started. Thank you.
that too. And then Matt and I will have this one.
Kate? Yep. All right, thanks everybody. With that, we'll go ahead and get started. And you know what I'd say is that, as many of you likely know, what happens in terms of the care of the trauma patient is much more than what happens inside an operating room. You know, it really is an all-encompassing process from the moment that a patient arrives to really not even their discharge from the hospital, but their recovery, rehabilitation, and reintegration into the community. And really, for those of you in the audience that are EMS, it starts with you and what happens at the scene. But many times, we don't have that benefit of knowing what each one of us does on the other side. So the purpose of this simulation really is to highlight how we can help each other and to show you a little bit of a comprehensive picture of a real patient's journey. And when I say real, it's a patient that we actually did have the privilege of caring for at Westchester Medical Center within the last calendar year. And hopefully the simulation as well as the case presentation highlights a few important things. Number one, the importance of communication. So pre-hospital communication and then communication once a patient arrives. Understanding what vital signs are in the field, what information you have before the patient gets to us, and then how we communicate with each other really is a matter of life and death because that communication can save lives. Number two, organization, right? It's not just about having the resources or having the skill and the expertise, but how is that organized and deployed? Is it rehearsed? Is it well organized and a well-oiled machine? And really, it should be, in the best of scenarios, a symphony of orchestrated activity, right? If you imagine a real musical symphony, this is very, very similar, except we're not playing instruments. We're actually trying to save someone's life. So that level of organization is absolutely essential. So with that, the simulation and the case presentation have to do with the same patient, again, who was cared for within the last year at WMC Health. So on October 30th of 2023, we received a report of a motor vehicle collision, a car versus a garbage truck, with a fatality. Someone died at the scene, and therefore a level 1 trauma activation was called at 4:03 p.m. Okay.
Okay, team, we have a patient coming in right now. We have an alert, a 17-year-old male head-on collision with a garbage truck. The patient is coming in. He has a left lower extremity laceration along with a left scalp laceration. 86 over palp, heart rate is 118, satting 90%. He's currently got a King Airway in, and they're en route to our trauma center, ETA 1614.
So with this pre-hospital notification and that kind of information, we're really able to be well prepared for anything, but particularly exactly what was described. We know that we have a really seriously injured patient on their way. So the first thing that we're going to do is assemble as a trauma team with all of the various team members knowing their roles and making sure that we have the appropriate PPE that's worn by all team members. So in terms of the MIST, we talk about this a fair amount in terms of the format of the communication that's given to us ahead of time and why it's so important. So from this information, we understand we have a head-on collision, a fatality on the scene. We heard about the deformity and the laceration to the scalp, but we also see here that this patient's in trouble, right? This patient is in shock. Look at the heart rate. They're tachycardic and they're hypotensive. They've lost blood. And they are struggling for air and for oxygen. So we also know that they were not able to be intubated, and that's a perfectly fine thing to do. We want to make sure that patients get to us as quick as possible with whatever kind of airway they could possibly have, and that the patient was given 5 milligrams of midazolam. And again, I cannot emphasize enough how important it is to use this format not only when patients arrive in that 30 seconds where communication is given to us, but actually in the phone call that is made, or whether using triage or whatever method you're using for pre-hospital communication, having these components has the ability to save lives, because it is only based on this information that we could be adequately prepared. Do we need blood? How much blood do we need? Do we need an orthopedic surgeon? Do we need a neurosurgeon? Do we need to open up an operating room? How many people do we need? Do we need an ICU bed? Those are time-sensitive decisions that are life-saving that can only be made with the benefit of the information in this kind of format. So go ahead. Dr. Bronstein is our trauma team leader as a trauma surgeon, and he's going to go through a series of steps to get things started.
So good morning, everyone. So first thing we're going to do is introduce ourselves so everyone is aware of who each one is in the trauma bay itself. So like Dr. Bakaran said, I'm Matt Bronstein. I'm going to be taking team lead for this. We have Mark Musicas, who is acting as our ER physician and on our airway. We have Dr. Huang, who is acting as our secondary physician and our procedural MD, so he'll be responsible for anything that needs to be done invasive, including chest tubes or invasive lines. We have Kate McGuire here, who is our nurse lead, and she'll be acting as our scribe. It's very important in the trauma bay to have adequate documentation of exactly what's going on. We have Brianna here, who is going to act as our primary nurse, who will help establish IV access, take some blood pressures, and help us with anything that needs to be done with the monitors and blood transfusions as well. Oh, and we have Susie, I'm sorry, in the back here, who's acting as our other nurse, who also will help with blood transfusions as well. And so in the trauma bay, there's often a lot of people. We sometimes have medical students. We also have respiratory therapy for the simulation isn't present right now, but always a lot of hands on deck, especially when we know we're getting a level 1 trauma activation with a critically ill patient who is inbound. The next thing that we always go through is our trauma checklist. So this is critically important to make sure that all of our equipment is ready and we're as prepared as can be. The nature of this is as nice as we usually get a heads up that the patient is arriving, so we're able to go through the checklist. Obviously, there are certain times when patients do just come across the ED without notification, but in this case, as in most cases here at WMC, we do have pre-arrival notification. So as you can see, the checklist, so that's basically the top part of the diagram is going to be how the room is set up with all the different physicians and team leads, and we also often have radiology for chest x-rays and pelvic x-rays as needed. And in terms of the checklist, It's important, as you can see here at the bottom. One of the key things is always to keep the room warm because we know trauma patients are always cold. Our equipment, we have ultrasound, so we can do something called a fast exam, which I'll go through later. And then we have our Mayo stands here, one on each side, which has all the equipment we need, which includes chest tubes, arterial lines, central venous catheters, and then other invasive thoracotomy sets and other special type of equipment such as the Reboa as needed. It's always important to have suction, especially when we need to get an airway, so there's always suction. There's Pleurovac set up. There's tons of IV lines, specialized IV lines. Now at Westchester, anytime there's a level 1 trauma that gets activated, 2 units of blood are automatically always released from the blood bank. They're uncross-matched blood in the event we need to give it. And that's pretty much it as we go through the next part.
So now our patient's arriving, it's 16:14, and we do a 30-second timeout so that EMS can give us a report. We try to keep the room nice and quiet, so I'm going to hand it off to them as our patient is arriving.
We have a 17-year-old male restrained in the back seat of a car at unknown speed. Left lower extremity deformity, laceration to the skull, GCS 3, heart rate 118, BP 86, pulp, O2 sat 90, ET CO2 52. We placed a C-collar and gave him 5 milligrams Versed. Unknown speed, patient was unresponsive on EMS arrival, and we had an LMA airway placed. End of mist.
Great, thank you so much for that report. So we immediately go into our primary survey, which follows a pretty simple pathway, ABC. So as I begin the ABCs, the rest of the team will start to establish a blood pressure and get some IV access. So for A is airway. So as you can see, he has a LMA tube in. It looks like we are able to ventilate. We'll continue ventilating through the LMA. Next, I'll move on to breathing, in which I'll just listen for his lung sounds. He's got bilateral breath sounds. As Brown has said, he is hypotensive. I am now going to C for circulation, in which I will palpate his central pulses. He has a weak and thready femoral pulse, but they are bilateral. We will then proceed to D, which is disability, in which I will look for his Glasgow Coma Scale, which is a scale of his neurological status, which includes his ability to talk, open his eyes, and have purposeful motor movements. The highest is a 15. The lowest you can get is a 3. He currently is a GCS 3. I'm trying to, sir, please wake up. There's no response on any of extremities or eyes, so he is a GCS 3 at this time.
And Dr. Prabhakaran, if you could just advance the slides, we can see right now his blood pressure, as Brianna just called out, is 40 over palp. His heart rate is 107. His respiratory rate is 12. We have established IV access, and the nurse is drawing blood right now.
So he is in severe hypotensive shock. So Dr. Wang, let's please prepare to intubate the patient, mark at top, and at the same time we will establish large bore central access with a cordis introducer, which is a very short and thick line, which will allow us to transfuse blood in a rapid fashion. At the same time, I will activate the massive transfusion protocol, in which multiple units of blood are released from the blood bank. Typically, we get 6 of blood, 6 of fresh frozen plasma, and a pool of platelets in order to transfuse him rapidly. All right, so let's prepare to intubate. Let's use RSI, rapid sequence intubation. We'll use etomidate and succinylcholine. And let's confirm the airway. As this is going on simultaneously, I'm going to perform what we call the secondary survey, which is basically a head-to-toe physical exam, which I'll start at the top of the head and make my way all the way down the patient's body. For this, I'll just kind of go through the pertinence, but as you can see, his eyes, his pupils are not very reactive. There's really no signs of massive head trauma. There's no crepitus to the chest. His abdomen is soft, but it is distended. And we will obviously expose the patient completely to make sure that there's no obvious injury. But he does have an obvious left hand open injury here for the part of the simulation. as well as an obvious degloving injury to the leg. And on the abdomen, there is signs of the seatbelt sign, which is concerned for abdominal trauma. And again, back at the back of the head, we do have a significant laceration to the head, not actively bleeding at this time. All right, so we're going to do a fast exam, like Dr. Wong said. So basically, that is what we call a focused abdominal sonogram for trauma. We look at 4 quadrants. We typically start at the heart to look for any fluid around the heart, which is called pericardial tamponade. In this case, his heart looked normal, but we then do look at the 3 quadrants in the abdomen. We look at the left upper quadrant, looks for fluid between the spleen and the kidney. We look in the right upper quadrant, which looks for blood or fluid between the liver and the kidney, and then we look for fluid down in the pelvis around the bladder. And our patient, the FAST was positive. As you can see here, there's a little black stripe, which suggests there is fluid in the abdomen.
And in this scenario, a positive FAST or positive fluid is always blood of the abdomen until proven otherwise. In the setting of somebody who's hypotensive, it means that we know that we're obviously headed straight to the operating room. There's no other place that this patient is going to go without dying. This patient's not going to go to the CAT scanner. They're not going to go to radiology or x-ray. They're going to go straight to the operating room.
And at this point, Dr. Wong has already performed a left femoral cordis. We have a right femoral A-line. We have bilateral chest tubes placed, and our MTP is running. As you can see, Susie is doing a great job with a balanced resuscitation, which Dr. Prabhakaran can speak more on.
Yeah, that's something that we've learned certainly from our military experience as a country through the various wars since really World War II, that, you know, really it used to be that we used to give a ton of crystalloid to these patients with lactated ringers, normal saline, and we have to remember that when people bleed, they're not bleeding lactated ringers or normal saline, they're bleeding blood. But when they bleed blood, they're not bleeding packed red blood cells or fresh frozen plasma. Those are the components that we bank in the United States for the most part. So when we give patients that are bleeding blood products, it's very important to make sure that we have a system that gives them these products in a matched fashion with blood, plasma, and platelets in a ratio that is optimal so that they do not become coagulopathic where their blood doesn't clot the way it should, because then they're going to continue to bleed. So at a level 1 trauma center such as ours, our blood bank actually has these coolers already pre-packaged with the appropriate ratios, and they keep coming until we say stop. And it's not uncommon to give, 40, 50, 60 units of blood along with the other products to the most severely injured patients.
And if you can recall, the patient came in with 40 over palp. We've now started an MTP, massive transfusion protocol, currently at 1626, which is 12 minutes after the patient arrived. Our BP is 63 over 46 from the A-line. Heart rate is 147. Satting 100%, now intubated. End tidal CO2 is 30. Again, MTP is ongoing.
And we now no longer have a femoral pulse, Dr. Wong, let's prepare to do a thoracotomy. Brianna, please start CPR. CPR is ongoing. Let's perform a thoracotomy. The purpose of this is we'll be able to manually do chest compressions as well as cross-clamp the aorta. And so we basically open the chest in the 4th to 5th intercostal in order to get control of any bleeding in the chest as well as cross-clamp the aorta. So we've opened the chest, and we are now putting a large clamp on the...
And as we open the chest, we retain ROSC, and we now have a blood pressure of 88 over 39 with a heart rate of 135. So we can stop manual compressions, and we are going to give some medications per Dr. Bronstein.
Yeah, we'll give him some calcium since he's gotten quite a bit of blood transfusion as well. We'll also give him a gram of TXA, which has been shown to help stop bleeding, as well as some antibiotics since we are doing this in an unsterile fashion in order to try to save this young person's life.
And during the thoracotomy, Dr. Bronstein also nudged me to make sure the OR is aware that if we get ROSC, we are going right up. So we are prepared for the OR.
Since we do have, ROS stands for the return of spontaneous circulation, he does have a heart rate as well as a blood pressure, and we are now going to plan for the operating room as we know that he is bleeding in his abdomen because the FAST was positive, and we will package him up and roll up to the operating room. Let's go.
So in reality, this patient did go to the operating room, and we'll talk a little bit about this exact same patient. Everything that you just heard was exactly the way that it happened, and what you're about to hear is the story of this patient, who you will actually have the privilege of meeting later, along with his family. So as you heard, this was a level 1 trauma activation for us, and especially in the summer months, we get multiple of these per day. But this happened October 30th of 2023, and the injuries and how the patient came in, you already heard. But it was a 17-year-old male involved in a motor vehicle collision against a garbage truck. So we recap that he was intubated on arrival. He got the massive transfusion protocol. He was hypotensive and in shock, found to have several injuries noticeable in the trauma bay without CAT scans because he wasn't stable enough for them. We knew that he was bleeding in the abdomen, and we knew that he had to go to the operating room, but prior to being able to even do that, his heart stopped. And that's why he had a thoracotomy or an ED thoracotomy, after which we were able to get a pulse back and he was taken to the operating room. Now, later on the pictures show the injuries that he has, and I'll go through that a little bit, but in the operating room, he had a laparotomy, or opening up his belly. We had to remove a fair amount of the small intestine, his colon, fix his liver, place some chest tubes, and he was so sick that this is not the time to do definitive surgery. This is called damage control surgery. So we place a temporary covering on his abdomen so we can bring him back to the ICU, optimize him, resuscitate him, kind of tune him up so that we can bring him back when he's a little bit more stable in a day or two to do more definitive surgery. And as a measure of, how sick he really was, well, I think someone's heart stopping gives you, a fair window into what kind of seriousness we're talking about. But just through the course of the operation, he ended up receiving, again, a total of 23 units of blood, along with all of the other products that are needed to kind of match that so someone doesn't become coagulopathic. But, in addition to the findings in the operating room, you can see here on these pictures that this is a massive liver injury right here. This is a spine injury here. You see the blood in the pelvis here as well. So in the first 24 hours, if you count what happened in the emergency department and in the operating room and then in the ICU, 70 units of blood, 70, along with all of the necessary products. And I won't even go through this because it's so long, but those are the injuries that we found, including what was discovered in the operating room, as well as what was discovered on CT scan. So this is about as severely injured as one could possibly be. So over the next several days, we were able to kind of take him back to the operating room when he was more stable. His chest and his abdomen actually became one cavity because the muscle that separates that is called the diaphragm. That's what helps us breathe, and that was completely torn apart as well. So we're able to do really definitive surgery by being able to kind of repair that diaphragm muscle, bring out a colostomy. He ended up having surgery with orthopedics for his femur, and over the next few days, we gave him a feeding tube, fixed a couple of hernias where different tissues in his body had just kind of completely been torn apart, took out his gallbladder because that was injured as well, and we're finally able to close his abdomen definitively. And on hospital day 8, he actually had lumbar spine surgery for his lumbar spine and his thoracic spine by neurosurgery. Over the next several days, on hospital day 10, he underwent a tracheostomy as we anticipated that he would need the help of a ventilator for quite a long time. He had more orthopedic surgery as well as laceration repairs by our oral and maxillofacial surgery team on hospital day 17. And on hospital day 31, 1 month into his hospital stay, 1 month, he finally was able to have the tracheostomy removed. And then he spent a couple of more months in our hospital until on hospital day 51 in the hospital, he was finally discharged to inpatient rehabilitation. At that time, he was speaking, talking, and eating. So again, we will hear a little bit more about him today, but we also mentioned something that people often think about and talk about, and that is the concept of an ED thoracotomy. Very important to understand why it's done, how it's done, and when it's done. And again, for those of you who are in EMS, it's something that you may have had the chance to witness if you stick around the trauma bays after you drop off your patients, but sometimes may not know that we are doing it. So the question becomes, why do we do it, when do we do it, and how do we do it? So there are guidelines that are out there in terms of our national major societies about when to do it. Typically, in blunt trauma, so not gunshot wounds, not stab wounds, but motorcycle, motor vehicle, so blunt trauma, the outcomes are not very good, right? It's really beneficial in stab wounds and gunshot wounds to the belly and to the chest. This is one rare circumstance where it was beneficial. And of course, especially in a younger patient, but in any patient, we're going to do all that we can to try to save a life, even if the societal guidelines tell us otherwise that may not be successful. So why do we do a thoracotomy again? Try to control hemorrhage. Number two, the pericardium, which is the sac that the heart is contained in. Sometimes if there's an injury to the heart, that can fill up with blood, preventing the heart from contracting, so you can actually release that. Open cardiac massage. There really is no benefit to CPR in trauma, right? CPR is what people get when they have heart attacks out in the community. But when you have trauma, you know, if you have to open the chest, you do CPR with your hands right on the heart, not on the outside of the chest. And we can actually cross-clamp thoracic aortic occlusion. And this is what I'm talking about, controlling hemorrhage. This is the pericardium that we can open, and sometimes you can actually evacuate a big clot here that can help save a life. Cardiac massage, always do with two hands, not one. If you do with one hand, your thumb will poke a hole in the myocardium in the heart, so you have to cradle the heart between two hands and massage it like this. And the thoracic aortic occlusion is just simple plumbing and mechanics. Once we're in the chest, if we can put a clamp on the aorta that feeds the blood to the rest of the body down below the chest, well, if that's clamped, well, there's no blood going to any of those organs, so you can't bleed anymore. So that's a clamp that we can place. That's not a permanent solution. That's a temporizing measure until we're able to get to the operating room and definitively fix what the injuries are. And that's really all I have. Hopefully that was educational. But again, you know, we're so grateful to have been able to, you know, save this person's life, and certainly for all the lives that we're able to affect, save, and improve. We're always grateful, but you know, my take-home message certainly, and I think our take-home message from this is a few things. Number one, on our end as a trauma center, what are the resources that we have and that we need? We're grateful. We've been doing this for years, for decades, so we're a well-oiled machine. So how do we make sure that there's resources are always there, rehearsed, and well employed with organization? And then for you who potentially are out there that are bringing these patients again, that communication before you bring the patient to us, and then once you bring the patient to us, what were you able to do in the field to start to save a life? What medications did you give? What have you noticed? If you can give that information to us in a structured format, those seconds, those minutes that we're able to have to prepare based on that information will absolutely end up saving a life. So thanks for your attention, and I appreciate it.
Thank you, Dr. Prabhakaran. At this point, everybody that's in this room is going to go back to the two workshops. So there's pelvic fracture stabilization and then knee decompression. They are just finishing up. So if you want to head that direction, grab a cup of coffee. There's two separate rooms. You're going to see them marked, and you'll be going into those rooms in the next couple minutes.
All right, thanks everybody. So I'm being told by Mark that, so we're gonna be here until 11:50, and then we'll break for lunch and then reconvene for the afternoon portion, which again is going to highlight our distinguished visiting professors, a couple of honorees, and again, the crown jewel, which is gonna be our patients and their families that are returning to us as survivors. And speaking of, one of our survivors' story is actually represented in this simulation and case presentation, which together tell the story of one person and their journey. So, the purpose of this simulation really is a few things. Number one, kind of focusing on communication. Let's remember that, it's so many people, it takes a village to take care of one trauma patient, but how do all those people get on the same page from the time that the patient is encountered at the scene to when they come to the hospital and the symphony of activity that occurs in order to save that one life? How do we make sure that there's adequate communication and how is it well structured? Number two, resources. Being a level 1 trauma center is a big responsibility, especially when you're the only one in the entire Hudson Valley. This expertise and the skills and the knowledge is there, and so are the resources, but how are they well organized and deployed appropriately when situations arise? And how do we make sure that all of them are kind of orchestrated in kind of a symphony type of fashion to make sure that we achieve the best possible outcome for each patient? So we'll start with this story, which again is a true story. On October 30th of 2023, level 1 trauma activation was paged out at 4:03 p.m. And this is actually a real picture depicting the scene of the accident. You can see the damage done to the actual vehicle. And for us, this represents the highest acuity of trauma activation, which we call a level 1. We're a level 1 trauma center, which is the highest level of trauma center that you can be. But within each trauma center, activations in terms of how sick patients are, this is about as sick as you can get, so we call it a level 1 trauma activation.
Actually, we have one of the EMS representatives, two of the EMS representatives that brought this patient in, so thank you again. So we received a report from them at 16:03 that a patient came in, 17-year-old male, MVA, head-on with a garbage truck, level 1, fatality on scene, left lower extremity deformity, head injury, GCS is currently 3. EMS is going to be placing an LMA. They have a SAT of 90% with an end-tidal CO2 of 52. They provided 5 milligrams of Versed on scene and have placed a C-collar. We are expecting the patient in roughly 5 to 10 minutes, so we are paging out the level 1 trauma activation.
All right, so as the trauma team puts on their PPE, we start to get ready for everything. And so we have all team members that are present here. I'm Matt Bronstein. I'm going to be acting as the trauma team leader. We have Dr. Huang over here, who will be acting as our secondary physician, as well as our procedure MD, which will help with invasive lines, chest tubes, any type of invasive procedure. We have Mark Musicus, who is going to be on our airway and head of the bed. And then we have our three nurses present in the room. We have Kate McGuire, who is acting as our scribe. It's critically important to have accurate information as we go through the trauma in real time. We have Brianna, who is acting as our primary nurse, who will help establish IV access as well as blood pressure. And we have Susie over here, our secondary RN, who will help with blood transfusions, as well as anything else that needs to be set up for the incoming trauma. As we prepare our room, it is also critically important that we go through a checklist for which we have in the trauma bay itself. And so we've already huddled, we've introduced everyone. In the actual trauma bay, there's often some medical students as well as radiologists, radiology techs, for x-rays, as well as respiratory therapists. So you can see in the top portion of the slide, this is exactly what the team looks like, all the different personnel in there. And at the bottom of the screen is our checklist, which we go through prior to every activation that we have. And so it's important that we have the room warm, excuse me. That's because trauma patients are always cold, even on a hot day like this when they're bleeding. It's important to have ultrasound equipment that allows us to do what we call a fast exam, a focused abdominal sonogram for trauma that looks for fluid in the abdomen and around the heart, which we'll discuss as we go forward. We have our 2 Mayo stands, which have all the equipment we need, including IV access, chest tubes, arterial lines, and anything else we may need to help save a life. It's important to have suction in terms of airway, so we're able to suction it clean to intubate the patient. And anytime we have our rapid transfuser back here, which allows us to transfuse large amount of volume in a very short period of time. And anytime a level 1 trauma is activated, 2 units of uncross-matched blood are automatically released from our blood bank per protocol.
And that's the level of organization that happens on our end as before the patient even arrives. But you know, what happens in terms of the communication before the patient gets here is something that I don't want to gloss over. And that's where we get into this, right? This is the MIST format that we ask people to not only give us the information once the patient arrives, which we'll see in a little bit, but even by telephone or triage or whatever method you use, if we're able to get this information, we get a lot out of it, because here we understand that, you know, having a fatality on the scene and having this kind of accident really tells us that we should be prepared for the absolute worst. We should always be prepared for the worst, but here the worst may be reality. And number 2, what injuries have you already noticed, right? Knowing that we have a fracture, knowing that we have a laceration to the scalp, is the patient bleeding? Having those vital signs. This patient is struggling for oxygen. We know that, right? So we need to be prepared for potentially a difficult airway. We know that the patient's heart rate is higher than their blood pressure, which is indicative of shock. This patient is bleeding. We need to get blood in the room, and we need to be ready potentially for the operating room and for an ICU bed to become available as well. What medications were they given? Given midazolam. So, you know, how long is that going to take to wear off? Do they have a brain injury? What, you know, what's their Glasgow coma score? So again, you know, this form that we call the MIST form is really important, and certainly, you know, 30 seconds, we always try to practice that, even though it happens fast once the patient comes. But the more information we can get before the patient even gets to us, certainly the better in terms of being, you know, adequately prepared for all that we need to actually be prepared for.
So at this time, it's been now 6 minutes. EMS is arriving with our patient. We see them coming through the door.
We have a 17-year-old restrained passenger, MVA head-on with garbage truck, left lower leg deformity, laceration to the scalp, GCS 3, heart rate 118, blood pressure 86 over pulp, sitting at 90%, end tidal 52. He was unresponsive on scene. We placed the C-collar, and laryngeal mask airway was placed. Ms. Stover.
Thank you very much. We will take over now.
Great, thank you. So first thing we'll do is we go through what we call our primary survey, which is pretty easy, A, B, C, D. So the first thing is the airway. He currently has an LMA in. We're currently able to oxygen ventilate. We'll continue that. I will then move to B, breathing. I'll listen for breath sounds. He does in fact have bilateral breath sounds. I'll then move on to circulation. I am feeling for his femoral pulses, which are central pulses. He, in fact, has bilateral pulses. They are thready but palpable. Moving on to D for disability, I will go through the neurologic status, the GCS, the Glasgow Coma Scale. That looks at his eye opening, his verbal, as well as his motor movement. There's no response. The lowest score is a 3. He gets 1 for each, so he's currently a GCS of 3.
During this time, our primary nurse has established IV access. She's got bilateral AC number 16s. She's also drawn some labs and gotten a manual blood pressure, which is 40 over palp. Heart rate is 107. Respiratory rate is 12. We are getting a VBG.
Great. So we have now activated the massive transfusion protocol. as we know that he is clearly in shock, likely hemorrhagic. Simultaneously, I'll ask Mark to prepare for intubation for a better secure airway. We will plan for RSI, rapid sequence intubation. We're going to use etomidate and succinylcholine for that. At the same time, I'm going to ask Dr. Huang to please start putting invasive lines, such as an arterial line, so we can have continuous blood pressure monitoring, as well as what we call a cordis introducer, which is a large bore resuscitative line. As many of you know, in these situations, we need short and fat lines to be able to put as much blood and product into someone in the shortest amount of time. So blood is now going. I'm now going to perform what we call a secondary physical exam as the team continues to work with the arterial line. It's basically a head-to-toe physical exam for which I typically start at the head as we continue to ventilate. And he has a large open degloving injury to the scalp. It's not actively bleeding, but there's a clear fracture. As I move down his chest feels stable. On his abdomen, it's distended, and there is a seatbelt sign from the seatbelt itself. His left hand does have an open, what appears an open fracture with laceration, and his left lower extremity clearly has a deformity for which he is in we will put a knee brace on at this time. Simultaneously, after we've established access and the blood is going, Dr. Wong is going to perform what we call a fast exam, which is focused abdominal sonogram for trauma, which looks at 4 quadrants. The first one typically will look at the heart, the pericardium, to look for any signs of blood around it for tamponade. In this case, he did not have any blood up there. And then we look at 2 upper quadrants, the left and right. We look at the recess between the spleen and the kidney on the left, and the same thing on the right called Morrison's pouch, which is between the liver and the kidney. And in this one, you can clearly see it's positive, suggesting that there is, in fact, massive hemorrhage or blood in the abdomen. And that is depicted by the black stripe between those 2 organs. And the last place is the pelvis. We look at the bladder as well as the pelvic in general. The patient continues to do poorly, and we don't have any signs. We know the fast is positive, but he is doing really poorly. So at this point, we're going to put 2 chest tubes into each side of his chest, as well as a Foley catheter.
We're also getting new vital signs now. So it's 16:26, so 12 minutes have passed. Our blood pressure off our A line is 63/46. Our heart rate's 147. The patient's now intubated with a respiratory rate of 20. O2 sat is 100%, and tidal CO2 is down from 52 to 20. And now we're continuing to put in our tubes and lines. The blood pressure, Dr. Bronstein, is 26/16, and I don't believe we have a heart rate if you want to check for a pulse.
Yep. There is no pulse. Let's begin CPR. Dr. Wong, prepare for emergency resuscitative thoracotomy. This is done in the setting of trauma, so we can access the heart manually. We typically go between the 4th and 5th intercostal, right at the nipple line. We do this right in the trauma bay. This gives us access to the heart. We're able to open the pericardium to look for blood, as well as cross-clamp the aorta to prevent any blood from going down to the abdomen, for which we know he's clearly bleeding based on the fast exam.
As we're doing this, Dr. Bronstein just asked that I make the OR aware that we are opening the chest, and if we get ROS, we will in fact be going to the OR. So now we've been in the chest. We now have new vital signs. The arterial line's reading 88/39. We have a heart rate of 135, so we've achieved ROS.
Great, so we now have, like Kate said, we have ROS, return to spontaneous circulation. Let's prepare to give him calcium, TXA, and let's plan to go to the operating room for emergent laparotomy, as we know the source of bleeding is likely in the abdomen. Let's roll.
So, that again represents the reality of what we do day in and day out, but also, the case of a specific patient. So let's talk about this patient and what happened to them after their course in the trauma bay and the emergency department. Just to recap, what you heard was, again, these pictures representing a very, very severe injury with a patient that was in shock, hypotensive, with a laceration and a deformity. And as you now have heard, the patient, got a massive transfusion protocol. We can talk about that briefly. That basically means that that's a lot of blood. It's massive transfusion, but it's not just blood. we recognized over the years that, we don't want to give lactated ringers or saline to bleeding patients. It just makes them worse because it makes them coagulopathic. We want to give blood, and in the absence of being able to give whole blood that's starting to come around in civilian worlds, we're able to give balanced transfusion, or blood products, packed red blood cells, plasma, and platelets, and we actually have designed our own system so that they're delivered in tandem to the trauma bay continuously until we say that we don't need it. We'll talk a little bit in a few slides about what an ED thoracotomy is, and as you know, the patient was taken to the operating room. Notice that we do have CAT scans, but these CAT scans were obtained after the operating room. Stable patients go to CAT scan. Unstable patients don't go to CAT scan, so this patient went to an operating room. There's a lot here that we had to do in the operating room for multiple times over. In addition to doing the thoracotomy, we had to remove a fair amount of his small intestine, his colon, and he was so sick that we were not able to do definitive surgery. This is called damage control surgery. It's taken from the military maritime industry, actually. When a ship has a big hole in its hull, you have a damage control mission. How do you make your essential mission and get to shore? And the same thing here. This is not the time to do definitive surgery and put all the stitches in and close the belly. You place a temporary covering, go to the ICU, resuscitate, optimize the patient, and bring them back as many times as you need until the patient gets stabilized for definitive surgery. And just to give you a sense of how sick the patient was, through the course of the operation, 23 units of blood, 23 units of plasma, platelets, cryoprecipitate, and so forth. And, what we found here in the operating room was devastating for the patient. Certainly depicted on these slides. The patient had a pretty devastating spine injury, a liver injury, and also the diaphragm had completely been torn. The diaphragms are our muscles that help us breathe, but also help separate our belly from our chest. Well, for him, it was all one cavity because the diaphragm had just been completely torn apart. So we did as much as we could in a safe manner in the operating room at that time. And within the first 24 hours of his care, we're talking about the emergency department, the trauma bay, the operating room, and going to the ICU, 70 units of blood with plasma and platelets and cryoprecipitate to match. I mean, that's how sick this individual was. And I'm not going to read it out, but I put it up here. Through the operations that he had and the CAT scans and x-rays that he had, these are all the injuries that he ended up having that this young man had to recover from. So over the next several days of his hospital course, he went back and forth to the operating room, now for definitive surgery, right? Bringing out colostomies, fixing his broken bones in his femur, giving a feeding tube, closing the belly, having our neurosurgery colleagues operate and stabilize his spine. Through the course of his stay, he did need a tracheostomy because he needed the help of the ventilator for quite a while. He had definitive repair of a lot of his facial injuries as well as his broken femur. And finally, on hospital day 31, 1 month into his hospital stay, we were able to remove the tracheostomy. And then thereafter, on hospital day 51, almost having spent 2 months of his life in the hospital, he was discharged to inpatient rehab. And at that time, he was talking, walking, and eating. So really a remarkable story of youth and courage on his part. And certainly all of us in this room are just facilitators in his remarkable story. Just a few words about ED thoracotomy. It may be something that you have seen for those of you in EMS, if you stick around to see what happens to a patient. It may be something that you've seen on television or read about in textbooks, or maybe not be something that you see. And certainly part of my job is to kind of let people know what happens on the other end after patients are dropped off. Because when patients need ED thoracotomies, A, they're really sick, and B, there's a lot of crowds in the room trying to see what's going on, or at least trying to lend a hand. So, there's a lot of societal guidelines that help us give some, guidance about when to do it, how to do it, when to do it, or who needs it. This young gentleman was very lucky. Typically, ED thoracotomy means opening the chest in the trauma bay with a knife and scissors. Typically has the best outcomes in penetrating trauma or stab wounds and gunshot wounds. Blunt trauma, such as motor vehicle accidents and car accidents and motorcycles, typically the success rate is much lower, but certainly this patient that you heard about falls in the minority, and certainly we're always going to try to save a life if we can. Why do an ED thoracotomy? These are the basic premises, right? Stop bleeding, release pericardial tamponade, open cardiac massage, and thoracic aortic occlusion. Control hemorrhage, look, you can pack things, you can staple things, you have the chest open right in front of you. Releasing pericardial tamponade, well, sometimes if the heart's injured, the sac, which is covering the heart, called the pericardium, can be filled with blood. And just by releasing that with a knife and scissors and evacuating that clot, the heart is no longer compressed and can start to beat again. So that's an advantage of doing an edic thoracotomy as well. Instead of doing CPR, there's no role for CPR in trauma. CPR is what happens when people have heart attacks out in the community. In trauma, CPR from the outside really has no benefit. If you need to do it, you put in a Reboa, which we can talk about another time, or certainly do an ED thoracotomy. But if you have the heart in front of you, you need to do CPR. Well, now you actually have the organ of the heart between your two hands. You don't do it with one hand. That's how you poke your thumb into the myocardium and make a bigger hole in the heart. You do it with two hands. And thoracic aortic occlusion sounds fancy. It's really not. The aorta is the major blood vessel that supplies the rest of the body coming from the heart. And if you put a clamp on it because you're in the chest, that stops all the blood getting to the rest of the body. And if blood's not getting to the rest of the body, well, guess what? The rest of the body can't bleed, right? So that's a temporizing measure to kind of stop the bleeding until we're able to get to the operating room and take care of business. So I'll stop there just in time, 11:53. Hopefully that was, somewhat informative and productive, but at the very least inspiring, to see a story of really great teamwork, starting with the care provided at the scene of the accident and continuing on with the patient and his family in terms of their story of resilience and perseverance. So hopefully that was productive, but certainly please enjoy lunch, and then we'll reconvene here per the schedule for the afternoon's event. So thank you so much.
Thank you, Dr. Babakaran. As he mentioned, we're going to conclude the workshops for this morning. Take some time for lunch. Please be back here at about 12:40. We're going to begin the didactic portion where you're going to hear some great speakers. So for now, lunch is where breakfast was. Enjoy it, and then we'll see you back at 12:40.
Hi, Dr. Holcomb.
Okay, I'm gonna hang up, let me hang up the phone real quick. Okay. Can you see me okay?
Yes, we can see you. Can you hear me?
Yep.
Excellent. Do you want to try sharing your screen for your presentation?
Let's try it. This is always kind of
I
fun.
believe I gave you all privileges, so.
Choose a file, blah, blah, blah. Screen. All right, so I have to choose the file.
Not now.
So this is different, WebEx is different.
Oh, you shared a file, so that's a little bit different. Do you know how to share screen?
I did, let me try that again. Let's see, I'll share the screen.
There we go. I can see. Oh, excellent. Beautiful picture.
Yeah, but that wasn't my picture. WebEx like to record, okay, I'm okay with that. I don't know where that picture comes from.
I do have the file. If we can't share your screen, maybe we could share it here.
Let's see. What we do matters, does that come up?
I have the file, What We Do Matters, yes.
Yeah, it's kind of changed it dramatically, Kate.
So perhaps I have
Oh, it is.
AV
It's
here
on
as
your
well.
screen.
Would it be easier if
No,
we
no,
shared the screen?
You have it, look, turn around, look.
So let,
Oh, you had it up.
Guys, lunch
Just a minute ago.
hungry.
And then you can choose that, it's window, I think?
No, Kate, you had it up.
yep, I see it.
There it is.
There we go. So we could probably share it ourselves here, and then you could just talk. Does that work for you? Can you see it, Dr. Holcomb,
Yeah,
as I click through?
it's not changing on my screen.
What's that?
It's not changing on my screen.
It's not changing on your screen. No. How's about in this mode?
Yeah,
It is changing now?
yep.
Sometimes when it's in presentation mode.
I mean, is it problematic to you this way, or?
I mean, if this is how it's going to work, then this is what we'll do.
I mean, ideally, that should work.
Yeah,
No, it's not moving on my side.
it's not moving on his screen. Do you have any animation during your presentation?
I have one slide that's animated. It doesn't need to be. I have no sound, no movies. Yeah,
Okay.
it's now moving, yeah.
Because what I can do is I can have Dr. Prabhakaran just go through it as you're talking, or myself, standing at the podium and going through it, so this way it's not a problem for you. Unless
Does
you
it
want to
show-
try sharing your screen again. I'll come out.
Yeah, let me try doing that. It's better if I control the slides, right? That's
Yeah,
optimal.
at least I have it just in case though.
How do you have it, Kate?
So
I
if
didn't send
you,
it.
on the bottom panel, you'll see stop video, record, and in between is share.
Mm-hmm.
So when you click share, what do you want to share? So you'll click into share, and then you can write, instead of Microsoft Edge tab, there's something called window, and you can pick the window you want to share if your presentation is up already.
So a screen, right? I share the, or PowerPoint? There we go.
You got something coming up. So it might be just a different window that you have with the open PowerPoint.
But now it's not moving. It's moving on my side, but not your side.
If you hit share full screen and have your full screen open, just with the presentation, does that work?
Let's see, you're sharing Microsoft PowerPoint. Nope, I hit stop. I'd like to share, so I have the talk open, on my desktop. Oh my goodness.
So when you go to share, just hit share and you can hit entire screen. It should be all the way to the right. And then you can hit share again. I'll stop playing around.
Entire screen. I don't see that. I see
There's like a few
screen.
tabs open, and then if you hit entire screen, we might be able to see it. Is this your background on your desktop?
It is not. I don't
Oh.
know where that picture came from.
Is this ours, Jerry? No. Oh, okay. It's a special. I mean, worst case, Dr. Holcomb, we can share it and you can just go through it and, you'll talk and we'll listen as we go through.
Well, so I have it, it says I'm sharing Microsoft PowerPoint, with the,
Yeah, we're
you-
not seeing anything, unfortunately, on our end.
okay, well, stop that. Let's try that again. It just says screen. Should I share that?
We could try. Doesn't hurt. No, it's the mystery screen again.
X, the meeting window. Sharing WebEx. Stop that.
Can we turn his voice up a little bit? So that way when he's speaking, like we'll stay muted on our end during your speech, Dr. Holcomb. I'll have our end muted. And
Yeah.
we'll just click through your slides. So either Dr. Prabhakaran or I will click through the slides for you. And then at the end of your presentation, that's when we'll do questions and we'll unmute. And either Dr. Prabhakaran or I will basically gather all the audience questions during your presentation, and then we'll basically mediate the question and answer session with you in the audience.
Computer volume's at about 50%,
Good.
so if you raise it, his voice level will go up.
Can you try speaking again?
Sure. Can you hear me okay?
Yeah.
The louder you go,
How's that, Jerry?
that sounds great. If we could
You want to speak again, Dr. Holcomb? Just so we're testing your volume?
Yeah. Yep. Can you hear me okay?
Yes, very good, perfect.
Yeah, I'm not sure what. It's too bad.
It's okay, we'll share the screen on our end, the way that you can see it, so it won't be the full screen presentation, but I will, hold on, put it back up
Can we
so that
just-
you can see.
Yeah.
Yeah. So you can see this, Dr. Holcomb?
I can, yep.
Okay, so we can't see you right now, but Dr. Prabhakaran or I will continue to go and move the slides for you so that
So
you
I'll
can
just say
speak.
next. Yeah, so you want me to just say next slide?
Well, I mean, we're pretty intuitive, hopefully, but if we don't move it for any reason, feel free to let us know.
Okay, good.
Okay, so that's what we'll do during your time. And would you like me to keep the link open so that you can kind of see what's going on?
Yeah, that'd
All
be great.
right, perfect. So we'll be on mute up until we introduce you and say hello to you. And then we'll go back on mute during your presentation. And then following your presentation for Q&A, we'll unmute. So this way there's no feedback or distractions for you.
Sounds good.
All right. Well, thank you so much, Dr. Holcomb. I know you're having a lot of troubles down south, but I hope everything's well and your family's well.
Yeah, we're all good. Thanks, I appreciate it.
Good. All right. So I'll put us on mute and I'll see you again in a few. You know what this application is? Okay. Sure. Why is my best friend texting me right now? He knows what I'm doing. Everybody wants me to take a picture. All right. Well, we have a plan, everyone. everyone. Good afternoon, everyone. Can you hear me? We're going to get started in a few minutes. We do have some rows in this front open, so if anyone needs a seat, please feel free. Again, we have about 2 minutes till we'll start.
If I could just ask everybody to begin taking the seats. There are a lot of, for those of you who are standing in the back, please make yourself comfortable. This is a packed audience, but we do have some seats, in the middle. So please do make yourself comfortable, and then we can go ahead and get started. This begins the afternoon portion of the program. So I know many of you were here for the morning portion, but overall, now that we have most of you here, let me begin again by extending a very warm welcome to all of you for taking the time out of your schedules to come and celebrate this occasion with us today. This symposium is something that we organize each year and has continued to grow across the years. The care of the injured patient requires so many dedicated professionals across so many different specialties, from first responders to our EMS colleagues, from nurses to physicians to surgeons to therapists to social workers to rehabilitation personnel. As we often say, it truly takes a village. And at WMC Health, we certainly, enjoy and take privilege in our responsibility to provide trauma care, not just to a community, but to an entire region as the only level 1 trauma center for adults and children in the Hudson Valley and beyond. Certainly we get patients from Pennsylvania, Connecticut, other countries, and other parts of New York. So that's a tremendous privilege and a tremendous responsibility that we take great pride in. And today, we have the privilege of honoring some of our own providers that have spent decades of service to patients, to communities, and certainly to our institution. We have the honor of hosting some giants in the field of trauma and resuscitation that are listed in your brochure. And certainly our crown jewel of our program each year is remembering that at the forefront of all that we do, we understand that we're just really merely facilitators as healthcare providers. The true story, the true heroes, and the true center of this equation that we call trauma is the patients and their families and their stories. And that's probably one of the things that we're most proud of in terms of this symposium, that we make them the crown jewel of our program, and they will be our grand finale as they come up here and share their stories of hope and courage that help to inspire us to do what we do each and every day. So for now, for a few minutes, I'd like to just share some highlights of our program. I talked about Westchester Medical Center being the only level 1 trauma center for adults, and Maria Ferrari Children's Hospital being the only level 1 trauma center, which is the highest level for children in the Hudson Valley for, again, a population of 3 million people. But over the last several years, and certainly the decade that I've had the privilege of working here, we've really grown to now being a consortium of 5 trauma centers across the 10 hospitals that comprise WMC Health Network, from Valhalla to Good Samaritan Hospital in Suffern, New York, to Mid-Hudson Regional Hospital in Poughkeepsie, to our newest trauma center, Health Alliance Hospital, the Hudson Valley in Kingston, New York. So I just want to go through a few of these trauma centers and their significant accomplishments. Good Samaritan was just designated as a trauma center by New York State Department of Health about 1.5 years ago. And already, if we look at the last year and look at the first quarter, we can see that the volume of patients that are being taken care of with such amazing expertise at Good Sam continues to rise. And, and what we do here in terms of this symposium is something that we replicate for our EMS colleagues and other providers across the river as well. And I was proud to be invited to be a part of that as well. So Good Samaritan Hospital is really off to the races and doing amazing things for the care of the injured patients. At Health Alliance, as I mentioned, really honored to be able to receive this letter. We have amazing leadership there with our next speaker that I have the privilege of introducing, Mr. Josh Ratner. So now Health Alliance Hospital also is a provisional level 3 trauma center that's going through the American College of Surgeons verification process. And there too, we have symposia that highlight local speakers and some of the expertise that we have in a dialogue with EMS colleagues. At Poughkeepsie and Mid-Hudson, really proud within the last year to have undergone a very, very successful review from the American College of Surgeons. American College of Surgeons comes every 3 years to verify every trauma center, and usually their job is to point out some opportunities for improvement, but also to complement trauma centers on our strengths. And really, they had no opportunities for improvement, which is hard to believe. So really something that we're very, very proud of. And the reason for that is it's not just about the volume of patients that any hospital takes care of. It's about the quality. How well do we take care of patients? So at Mid-Hudson Regional Hospital, really proud that at that trauma center, we rank in the top 10% across the country of our outcomes amongst trauma patients. And I mentioned to you about, children and adults, and our first, professor who's speaking to us today is actually our chief of pediatric surgery. So I'll let him talk a little bit more about the care of the pediatric trauma patient. But again, this just highlights a little bit of our growth in pediatric trauma over the last several years as well, in terms of our volume continuing to rise. And really, our pediatric trauma center is the forefront of so many different community and regional initiatives, and being in the media for much of the education and injury prevention that they do. And they too, by the way, rank in the top 10% of all trauma centers in the country. So really amazing work for the children and across our entire region. Here at Valhalla, it's just been absolutely amazing. what a sustained increase over the last several years in the number of patients that are injured that we admit to the hospital and that we treat at our hospital at Westchester Medical Center. It's really, really amazing to see this volume of trauma, and the fact that as an institution, we remain so committed to trauma being a pillar of what we do and what we do excellently. It's not just about volume. Here at Valhalla, at our Level 1 Trauma Center, we too rank in the top 10% of all trauma centers in the entire country. And these top 10% rankings are not awarded by me or any other body except for the American College of Surgeons, which is an independent body that scores trauma centers on how well they perform. But again, it's not just about volume and quality, it's also about some of the outreach. We're really proud to be featured in several media outlets across the last year and a half, and we continue to do that over the last couple of months as well. This kind of highlights what we represent to the community and to the region as well. We take education and outreach very seriously. Again, I talked a little bit about our survivors and our patients and their families, and there's just a recent event that we had, a reunion of our trauma survivors that was featured on local and regional news channels as well. And certainly we're proud to put on these events like we're here today to celebrate. And certainly being leaders in the field of trauma is very important to us as well. And this is me and one of my colleagues having the privilege and honor of serving as the chair and vice chair, respectively, for the American College of Surgeons Committee on Trauma for really all of New York. So with that, just a few highlights again of what we represent at an institution, but now it's really my distinct honor to introduce a speaker who serves many roles for our institution. He's our Chief Strategy Officer for our entire health network, and he's also the Chief Executive Officer of Health Alliance Hospital in Kingston, New York. And more importantly, he's a partner, a colleague, and a friend who's been an amazing advocate, resource, and source of vision and wisdom. So with that, I'd like to introduce Mr. Josh Radner to deliver a few remarks. Thank you so much.
That's some introduction. Good afternoon, everybody. Hope you're doing well. I'm glad I'm not standing between the symposium and lunch, that's already behind us. As you just heard, I'm in the fortunate position of having a network role as well as having the leadership role for two of our hospitals up north. And what that means is I've been able to witness firsthand the collaboration that we have as a network with you all, the EMS provider community, hospitals that are outside of our network that we work with very closely, as well as our unbelievable clinical leadership team that we have across the network. In 2014, when WMC Health was formed, because prior to 2014 it was just Westchester Medical Center, we began to partner with local community hospitals to form this affiliation, to form this network. And unlike many other health networks, whose main vision for mergers and acquisitions is to try to suck as much of those referrals from the local community hospitals to the flagship hospital, WMC's vision is completely different. And our focus is not only to raise the bar, to elevate the clinical capabilities of the quality of the hospitals that already were in existence and had been serving the community for many years, and to bring as much of that up a level or two to try to serve the communities locally. In the end, there are patients that may need to be transferred to a higher level of care, and now with the consortium that we have different options for where those patients go. But our mission isn't only to take care of every patient, regardless of our ability to pay, or their ability to pay, but our mission is to reach out and really help educate and keep the communities healthy. And so partnering with you all is really essential in order to do that. Convening groups like this and symposiums like today are really sort of part of our core mission as a network. And so I just want to recognize and thank all of you for your partnership moving forward. I will tell you that if you look at Health Alliance, we became a trauma center in October, excuse me. And we have just over 300 activations of our trauma program. And what that means practically is there are over 300 lives that have been positively impacted by the ability to stay local, to get the care that they need, to stay close to their families, to stay close to their communities. And that is a huge life changer for many of our patients who previously might have had to go across the river or travel a long distance to get the immediate urgent care that they receive. So I'm going to keep it brief at that, but I do want to just end with thanking the team who, Dr. Prabhakaran and the whole team who formed and really organized this symposium. And again, thank you all for the partnership. WMC Health greatly appreciates it. Thank you.
Thank you, Josh. And with that, it's my distinct pleasure to introduce our Chief of Pediatric Surgery and Pediatric Trauma Medical Director at our Level 1 Children's Hospital Trauma Center at Maria Ferrari, Dr. Dylan Stewart.
I'm gonna have to set my timer so I don't go too far. All right, good afternoon. I'd like to say thank you to Dr. Prabhakaran and Dr. Kakuza for inviting me to speak. It's like, it's a real all-star lineup they've put together this year, so I'm very honored to be included, so thank you. And a big word of thanks to both Kate McGuire and Mark Musicus, who have put so much effort into this symposium, so it's great seeing everyone here, and they've done a lot of hard work, so congratulations to the whole team. I know we pediatric types like me, we have this stereotype that we're always whining about how children are not little adults. So that's why I chose this for my title, because I don't want to get painted with that, okay? But we are going to talk about kids today, who, when they go to a scene, is absolutely 100% comfortable when they see an injured child. No problem. Okay. And who is here today? Who in the audience is pre-hospital? So quite a few. How about in emergency nursing or early nursing? Okay. How about physicians? Okay, great. And how about other PAs? Do we have NPs here? So we really kind of have the whole spectrum. So what I want to talk about today is getting you more comfortable with children, so you don't have that feeling when you see an injured child that, wow, this is really not my day. I don't have any disclosures to make. It is true that pediatric trauma is its own thing. The initial trauma survey and the resuscitation, it shares some similarities with adults, but there are significant differences. This is due to unique anatomy, physiology, and then also factoring in developmental and social characteristics of children, which are different than adults. So these features have to be accounted for when you're in the field and in the trauma bay and in the early accurate triage and assessment when we care for kids. So that's really what I want to talk about today. But I also want to say you can do it, okay? Not every scene that you go to as an EMS provider is going to have, a healthy 25-year-old lying there quietly with a nice big antecubital vein just waiting for you, okay? You guys take care of all sorts of complicated patients. You take care of the frail elderly, you take care of obesity, you take whatever comes. And that's what's so special about pre-hospital and early nursing. You guys, you are the front line. So I say this every time I give a talk, but the best person to care for that kid is the person that shows up there to come and get them, okay? So I congratulate you all here for being here, taking your time to educate yourself, and I hope at the end you're going to feel a little bit more comfortable about it. Being ready to take care of kids is a real buzzword now. Pediatric readiness is spoken at all of our meetings where hospital systems like our consortium, we're taking a real hard look at, okay, are we ready to take care of children? And this is becoming a big national priority. So I'm not sure I'm happy that our trauma volume has gone up. It truly has. We have such an extensive injury prevention, so I hope, maybe Mark and I need to talk some more. I hope the reason we have more kids is that we're doing more things like this and you know about us, because we want you to to bring us those injured little adults. So, pediatric trauma is a disease. It has a huge national burden, okay? It is the #1 cause of death for children from age 1 to 18. Only in infants from 0 to 1 are congenital anomalies more common cause of death than injury. So we don't get the amount of attention that pediatric cancer gets or some other sort of pediatric very unique diseases, but this in America is why children die. There are over 9 million ER visits for injury in the United States every year. And it tends to account, trauma tends to account for almost half of pediatric ambulance transports. So I'm not sure if that's the number you feel, but that's what the nationwide data would show. And more than half of children who don't survive their injury don't survive in the field, okay? And I think that's a really crucial fact because it means you have such an opportunity to intervene and make a huge difference in the life of that kid. This is a fairly recent showing deaths per children and adolescents over the last few years. You can see that things like congenital anomalies, heart disease, have stayed relatively steady over the last 10 or 15 years. Malignant neoplasms have gone down somewhat, but still injuries, especially motor vehicles, and now this new spike we've had since the COVID pandemic in firearm injuries, okay? This has become a true public health epidemic in this country. So many children and adolescents are dying of firearm injuries. So this is something we all need to be. Every parent at my kid's elementary school, I know who owns guns in my kid's elementary school, put it that way. I won't let my kid go to someone's house unless I know, do you have firearms? And are they properly locked up, okay? And this is something, as a parent, this is your duty. And you can do this with your patients also, okay? It's your duty to encourage people, if your child is around firearms, make sure they don't have access and that they're safe from them. So what are the trends in injury? What is it that kills these children? Typically, it is traumatic brain injury, okay? Kids get head injury. That's the #1 problem that we take care of. And of course, the brain is sort of the last, it's the organ we can't really fix once it's too badly damaged. So kids get intra-abdominal and intrathoracic injuries, but they don't cause many deaths. And in kids, unlike adults, the blunt to penetrating ratio is very different. It's 12 to 1. Until you really get to the older teenagers in an inner city environment, you don't see the amount of penetrating trauma that our adult colleagues will see. And I put this all in caps because it's so important. Cardiac arrest. A child who's in cardiac arrest probably is not breathing or is hypoventilated. They probably are not bleeding to death, okay? That's just the way the facts pan out. I've been a pediatric trauma director for 20 years, and I have not taken out a spleen, okay? The spleen can shatter, and it can bleed, and it almost never kills the child, okay? So if your kid's in arrest, you've got to think airway, airway, airway in children. What other injury types do kids get? Orthopedic injuries obviously are very common. You all know about this, but they can be a sign of other injuries to look for. Again, I covered this, that firearm-related injuries have taken this rapid increase that we all really need to pay attention to. And my least favorite term, non-accidental trauma. That's the industry buzzword for child abuse. We talk about NAT. This continues to be a major national burden. This is across all socioeconomic spectrums. We saw a big increase during the COVID pandemic, and this is especially prevalent in the infant population, which really is kind of shocking, but it's what the statistics bear. The reason I bring it up with you is that the importance of a detailed, recorded history is so important. For us to know from our pre-hospital providers where they found that child, what the circumstances were, what they were told by the babysitter or the parent or the older brother. These things are critical to us in making decisions about how to safely care for these kids. So kids, their injuries tend to occur in these age-related patterns based on what they are socially capable of doing. So in the infants, again, we see mostly injuries that happen in their home environment. They can choke, there's strangulation, they can fall, falling off counters, falling off beds or changing tables, and then again, seeing child abuse in this age group is quite common. When kids start toddling around, now things change. They have an inquisitive nature. They are curious about things. They put their hands on hot stoves and they run across the street to get their ball. So we start seeing more falls, more pedestrian injuries in this kind of toddler school age group. When kids get into elementary and older school age, now they have this new sense of independence. So again, we see pedestrian versus car injuries, bicycle accidents when they learn to ride. We see animal bites more in this because kids run up to a strange dog. So these are the kinds of injuries we look for in that age. And then when we get to the adolescence, then we start seeing kids who are taking risks, being the stereotypical teenager, responding to peer pressure, and now we add in drugs and alcohol. We see kids driving, we get more sports-related injuries, and we start to see some penetrating trauma. This is some new information that I came across. Children in MVCs, it turns out knowing the circumstance of a crash is really important. Not just that they were in an MVA, but high energy frontal crashes. Those are the ones that tend to involve spine or long bone injuries, as it turns out in children, really across all age groups until teenagers. Or lateral crashes, if they're hit on the side, tend to have more chest and head injuries. So knowing what the circumstance of that accident would really help us. And then knowing the type of restraint that was used is extremely important. 80% of fatalities that happen in kids in MVCs is because they're not properly restrained, okay? Modern car seats are a miracle, okay? Kids can really come through horrible accidents if they're properly restrained, and by properly, I mean age appropriate, okay? Trust me, my 4-year-old wants to get out of 4-point restraints, but I won't let him. He's not big enough. He doesn't meet the criteria to be, you have to be 45 pounds, so he stays in his chair. I was looking for a picture of car seats. I don't know if I'll get in trouble for finding this. I think the WMC servers are going to think I was on the deep web or something. These are for sale. And someone advertised, yeah, here we got in a car crash, and here's our car seats now. They're for sale. So, first of all, that's illegal, right? So you can just have a fender bender, and you gotta dump the car seat. Now, most auto insurance, they'll buy you the exact same seat that was in that accident. So that's just a little tip that you can't reuse car seats that have been in an accident. So again, I don't know if we need, like, someone want to volunteer for a sting operation. I'll see if I can find this picture again. This is a really old picture that has sort of been refuted. They called this the Waddell's triad. But again, even though it may not pan out, it reminds you that it's age-related and they come in patterns. So Waddell, back in the 60s or 70s, proposed that children have these 3 injuries. The triad is a long bone fracture. So they run out chasing their ball. The car hits them. It breaks either femur or tib fib. Then they hit the hood of the car, giving them a thoracic or abdominal injury. And then they fly over and bonk their head on a rock. So they have head, intrathoracic, and long bone fractures. This was called the Waddell triad. And whether it really exists or not is not important. It's that you think about patterns when you're looking at a kid. When I see a child who I know has been hit by a car and has a femur fracture, I'm going to be very suspicious that they have an intra-abdominal injury. So knowing the circumstance, again, is a huge help to us when we're in the trauma bay. So what makes these little adults a little different? Number one, this is a great picture showing you babies. They're all head. Babies are just all head compared to an adult. So kids have a smaller body mass. They have less connective tissue than adults. They have closer proximity of organs to externally, and they have a larger body surface area to mass ratio compared to adults. When it's 90 degrees out, you don't think about this much, but in a cold ambulance in New York in February, the point is kids get hypothermic very, very rapidly. So watching a kid's temperature is incredibly important in cold climates like this. So what happens in their head injuries? What's different, they have softer bones, okay, and this allows more energy to be transferred to the brain when they're hit. Intracranial bleeding in infants is a very rare cause, but can be seen as an actual cause of hemorrhagic shock. A baby can lose enough blood and pump their fontanelle up tight enough they could actually be hypotensive. I know I told you kids don't often bleed, but this could be a reason why a hypotensive infant, if you feel their head and their fontanelle feels like it's about to explode, well, it might be. Loss of consciousness is very common in kids, but typically the problem it causes is that it makes them lose their airway. So things to look for head injuries, again, in infants, the fontanelle, looking for CSF in the nose or ear, looking for blood around the eardrum, looking for battle sign. These are things that we like to hear about from the field, and makes us much more suspicious the child has a serious head injury. Spinal cord injuries are quite uncommon in pediatric trauma, okay? Kids do have this ligamentous laxity and this large head to body ratio, but the injury that comes is not the same sort of spinal cord injury we fear in a 14-year-old that dives into a shallow pool. But C-spine immobilization is still very important, and it's still recommended, okay? We have gotten away from long boards, as everyone knows, but C-spine is still critical. And I put this up here. The ability to ambulate does not mean you might not have a spinal cord injury. So even if that kid that got hit by a car is walking around and looks great, put him in a C-collar, okay? It's very important to immobilize. Now, C-spine clearance, that's like well beyond that could be 2 lectures in itself about the way we try to clear the pediatric spine and all the algorithms we have, but it's very important to put kids in collars. When it comes to the chest, kids have some very significant differences. They have very malleable ribs and bones. They're not ossified. They're not bony yet. So that's why rib fractures or a flail chest in an infant or a 4-year-old, incredibly rare. We almost never see it. If we do see a rib fracture, that is a sign of major energy transfer to that kid. Okay, that means that kid has really suffered a lot of force in order to break that rib. Small children are also almost completely dependent on diaphragmatic breathing. Okay, kids don't have the same accessory muscles adults do, so they're at risk to go into respiratory fatigue and failure in a shorter time frame, perhaps an adult who can help compensate by using muscles, accessory muscles. The other problem in kids, their mediastinum is more mobile. So they get displacement or they get shift of their structures faster than, say, a 20-year-old. So a smaller pneumo or hemothorax might cause more disruption in a kid. In terms of abdominal trauma, we see serious abdominal traumas in about 10% of our admissions. The kid's abdomen is vulnerable because if you think about it, the rib cage is much smaller in a child compared to their little belly. So their ribs provide less protection to liver and spleen and kidney than they do once they've reached their full height. Another little pearl to talk about, I mean, I guess adults can cry at the scene too, but kids are, when they're scared, they scream and cry. Children can swallow an unbelievable amount of air when they get that upset, okay? And kids also are very vaguely sensitive. So you can have a child that suddenly is arresting, and it's because, and they have a huge stomach, and you think, gosh, they're bleeding, their IVC is ruptured. No, they've just swallowed so much air that they've now made themselves bradycardic, and simply dropping an OG and decompressing them, it's like the sun will come out, and they're back to normal. So always a thing to think about in an infant who's been screaming and crying at the scene. I said that skeletal trauma, it's very common. It's rarely an immediate cause of death, but it's probably what you're going to see more than anything. Upper extremity fractures outnumber lower about 7 to 1. But an isolated long bone or even pelvic fracture in kids are a very infrequent source of hemorrhage. So again, back to my capitalized slide that it's usually hypotension or arrest is usually more ventilation than hemorrhage. So yes, a kid could lose a fair amount of blood into bilateral femur fractures, but that's unlikely to be the source of their hypotension. And it's very important that dedicated orthopedic evaluation is made for these kids. Even if they're not seeing them immediately, these kids need follow-up because pediatric bones heal very differently, and the x-rays that kids have, and if they have growth plate injuries, these things need to be watched very carefully by a pediatric orthopedic specialist. The other thing that's troublesome in kids is you need all this different equipment, right? Everything needs to be sized differently in kids. We have this thing, most people know about the Breslow tape. I love these things. We still use them because you don't need to remember all this stuff. You lay the tape next to the kid, and wherever their foot ends, that's going to give you drug dosing. It's going to tell you what size C-collar, what size endotracheal tube. So having Breslow tapes on your ambulance is really important to help you know what you're going to be doing for these little kids. And of course, everyone's annoyed by this, but everything is weight-based, right? We do everything in per kilo in kids. So you need an accurate guess of what their weight is to dose any of their medications. And the Breslow tape will give you that. So again, most children who make it to the hospital and receive care will ultimately survive. Kids that do not typically are going to die from airway loss or traumatic brain injury. For an alert child at the scene, it's always very helpful, if you can, to bring in a parent or a caregiver, because they can provide a good history, which the child might not, but they can also keep a screaming child much calmer, which makes our evaluation much easier. I put these scores up. We don't use these in New York, but a lot of states do. If you were ever to move to Maryland, you'll learn there are these field assessment triage scores for kids. The reason to do these is to help you in the field triage and decide which child needs to go to a pediatric trauma center. So again, this is not mandatory in New York, but it's something you might see down the road. And there are a bunch of different scores, and it's not worthwhile going into which is better, but using one can really help you get an idea, okay, this kid needs to be at a level 1 center. So the ATLS, the classic A, B, C, D, and E's can be applied to an injured child just like an injured adult. We usually have a focus on their physiologic differences, but oxygen administration, watching the airway, controlling any obvious bleeding, stabilizing their spine, temperature maintenance, and getting an initial GCS. This is standard for any kid, and any of you can apply this whether you've ever taken care of a child or not. I do ask, GCS is important, okay? You can take a GCS on an infant. It's not easy, and it's a different score, but it's very important to us. It's very important to us to know in the trauma bay what that child's mental status was like in the field when they first got in contact with you. So learning how to do infant GCS is important. Unfortunately, you also need to remember a few age-related vital signs, okay? So the blood pressure, I wouldn't worry about quite as much because no matter what, it's going to seem low, and you probably, unless you're very peds ready, you might not have the right size cuff on your ambulance anyway. I worry more about the heart rate than anything. But a screaming infant with a heart rate of 160 or even 170 is probably not bleeding, they're just screaming, okay? And that number, even in 3 to 5, you know, what you would normally say, like, whoa, that's tachycardic in an adult, it may not be tachycardia in a child. So keep in mind these age-related differences when you're evaluating them. And again, airway, it's always the number one thing to establish. This doesn't mean you have to go out and intubate infants. Most airway interventions in kids are just simple maneuvers. Suctioning, putting oxygen on, clearing their, you know, making sure their head is in a neutral position. This is important, and I'm sure most of you know this already, but again, we said it, kids have huge heads, and they have a huge occiput, which pushes their face forward if they're lying flat. So it's important to get something underneath the child to get their face turned back, and sometimes it's literally all it takes to get a kid who's chin down to get them extended and their airway opens. So again, it's not all about intubating, but it's doing simple things like you would in an adult to make sure that they have an adequate airway. I bring this up in kids because it is important when we're in stressful situations. Kids have a much shorter trachea than adults do. It's really easy to main stem intubate a child. What's probably more important to think about is, I think it's my next slide, but when you're bagging a child, you have to be careful that you're not, especially if they're not doing well and you've got adrenaline going. Kids don't need as much pressure as adults do. And it's very easy to give a 2-year-old a pneumothorax if you're giving them 30 to 40, you know, if you're giving them too much PEEP or stacking their breaths. So, but most of the other airway adjuncts are the same. We suction, we pre-oxygenate. We don't use nasal airways in children because they simply just don't help until you get to adult size. They're just too small. But you can use an oral airway. ATS teaches, you know, not to do the little flip maneuver you do with adults sometimes. Kids' soft palate tends to be a little more sensitive, and a lot of times that plastic twisting around will cause bleeding, and now you've got a bad airway, and now there's blood in it. So avoiding that, but you can put an oral airway in a child, but we don't use nasotracheal intubation typically or nasal airways. Knowing the size of ET tube you're going to use, I mean, this is an algorithm everyone knows. I just tell people, look at the kid's pinky. That's about how big the tube is that they're going to need. But there are all sorts of, you know, the Breslow tape has this on it, which basically shows you, and there's all sorts of these formulas, which you're welcome to remember if you want. So in a 4-year-old, or yeah, a 4-year-old is going to get 4 divided by 4 plus 5. That's the size of their ET tube is going to be. So these are things to be thinking about if you're on a rig that's actually intubating. Here we go. Again, being careful with the bag mask. This is very important to avoid barotrauma. Doing needle decompression, same landmarks you use for adults. Okay, this is one part where it's just the same. If you're worried about a kid having tracheal deviation and you think they've got a huge tension pneumothorax, it's really the same as in adults. I always put this slide up. It's one of my favorites. It's old, this is like ATLS back in 1980. But what it's showing is that kids respond to, and I told you they don't hemorrhage, but sure, they can. Kids respond to bleeding very differently. They maintain their blood pressure. So what this chart is showing you is percent of blood loss. Kids keep their blood pressure stable up to almost a 40% total blood volume hemorrhage. They do it by increasing their heart rate. That's how they keep their cardiac output up. Okay, so it really is not until they become hypotensive that following right behind that, they're going to become bradycardic and arrest. Okay, so a hypotensive child is probably at the precipice here. So just because their heart rate is up doesn't mean they're necessarily bleeding. But again, when you start to see hypotension, you may be dealing with a really large blood loss, and you may be dealing with a pre-arrest kind of child. Tachycardia and poor skin perfusion. These are your best and earliest signs of significant hemorrhage. We still give kids an initial bolus of 20 cc's per kilo of crystalloid, but this is the same way this has changed in the adult world. This has pretty radically changed in kids over the last decade. We used to give all these boluses trying to avoid blood. Now, we really give a single bolus and we go right to blood transfusion. Again, we think kids can lose up to 45% without becoming hypotensive, but this progression is associated with a real risk of death. And now we know that giving all this excess colloid is bad for trauma patients too. So like the adult world, we have moved to blood sooner. It's important to remember what the blood volume of a child is. It's different. And in a 3-kilo baby who's lost 30 or 40 cc's of blood, that could easily be a third or 2/3 of their blood volume. So you have to remember that kids have, their blood volume is measured, again, cc's per kilo. And everyone gets worried about venous access. Again, the preferred sites are the antecubital fossa and then the saphenous vein. We usually tell people in pediatric trauma 2 attempts before going to the IO needles, which I know you're all familiar with, so you can skip over that. Aha, here's my infant Glasgow score. I think I'm going to give $20 to the first EMS who writes coos and babbles on, a run sheet. I would love to see that, okay? So, but you really you can tell us what the GCS of an infant is in the field just by knowing, what they're doing with their eyes, what they're verbally doing other than just screaming, and what kind of motor response they have. You can make this estimate without, going through the usual GCS questions. And then we talked a little bit about this exposure, okay? It's summertime, so it's hard to talk about getting cold, but you got to expose the whole kid to get a look at them, to see where their injuries are, but then you got to cover them right back up. Very important to keep children warm because there's nothing worse than having a bad intra-abdominal injury who comes in with a temp of 34 or 35. We have to keep children warm in the field. And then again, NAT or child maltreatment, I always have to bring this up. There's always this specter of child abuse that we all are responsible for thinking about and evaluating. The things I worry about are a discrepancy between the history and the actual physical injury. And a big part of this is if there's a discrepancy between what they told you and what they tell me. I've also had a babysitter look me in the eye and think I believe that a 2-month-old walked across a room and fell down some stairs. So what they're telling you has to be developmentally appropriate for that child. And also when there's a prolonged interval between when the injury may have happened, or if you think it looks like this is a prolonged interval, this is important information for us to do our NAT workup. And then this slide, I wanted to put up at the end. This is relatively new, but I think it's really important. New York has this program now called Always Ready for Children. This is a pediatric readiness program. I would encourage you to go to your hospital administrators or your emergency room and take this quiz through the Department of Health. Find out where your hospital is in pediatric readiness. And then as the regional pediatric trauma center, that helps us to know, and we can help do outreach, and we can help your pediatric program develop and make sure that you are always ready for children. And they have these different levels, that you're engaged, you're ready, and then the innovator really should be where we are at the level 1 centers. So I really encourage people to participate in this so New York knows what hospitals and what systems are ready. And this is part of our work as the consortium to reach out to these centers. We're trying to get all hospitals to have what we call a pediatric emergency coordinator, somebody who takes that role of making sure that, yes, you have the right size Aspen collars in your ER and you have small IVs and endotracheal tubes and whatnot. And this came out about a year ago, but this is really important. An injured child's chance of surviving improves when treated at a trauma center prepared to care for children, okay? So, and patients with the highest readiness score have lower death rates, but it's not just mortality, folks, and that's what I really wanted to stress. It's everything. Kids who come to a dedicated center, even for long bone injuries, for lacerations, for burns, they do better at a place that takes care of lots of kids. So we want we want you to bring us all the kids you think are going to benefit from this kind of pediatric readiness. And I think I'm right on time, and my email's up here. I'm happy to always chat with people, and this is why I do it, my 3 boys. Does anyone have any questions for me? Feel free to grab me later. I'll be around the rest of the day. All right, thank you very much.
Thank you, Dr. Stewart. Wonderful talk. It's really my privilege to honor and welcome our 2024 WMC Health Trauma Volunteerism Awardee, Dr. Augustine Moscatello. Dr. Moscatello has led the Department of Head and Neck Surgery for over 30 years at Westchester Medical Center. And during this time, he has operated on and provided life-saving treatment to thousands of patients and their families. Dr. Moscatello has been a leader in the field of otolaryngology on a local, regional, and national level, and has trained several generations of surgeons. He has served as past president of the New York Head and Neck Society, and here at WMC Health, under his leadership, the department has been instrumental in providing timely and expert care for patients with severe craniofacial injuries and has helped to save lives, reduce deformity, and allow trauma patients to regain their voice, their hearing, and their vision. Whereas countless individuals across our communities, region, and the state of New York are grateful to Dr. Moscatello for his career in surgery and medicine, we're here today to actually recognize his global volunteerism. During his career, Dr. Moscatello has led or participated in more than 24 medical missions worldwide, ranging from Cuba and Vietnam to Thailand, India, and Ethiopia. More recently, Dr. Moscatello mounted a mission to Ukraine, where he operated on and treated civilians and soldiers in the war-torn country afflicted with devastation. After touching down in Krakow, Poland, he spent roughly the next 12 hours riding a bus and being cleared by security checkpoints en route to Western Ukraine, where the patients were waiting. There, his days often began at 5 a.m. and ended at 11 p.m., frequently amid the ominous din of emergency alerts and air raid sirens. I'm pleased to share this video about Dr. Moscatello.
3 decades-long career. Now he's telling his story to our News 12's Nadia Galindo, who's got this report.
They had all the atrocities there.
War did not deter Dr. Augustine Moscatello from going to Ukraine. It's what drew him to the country.
You say, I wish I can do something.
The director of otolaryngology at Westchester Medical Center joined a group of doctors on a 10-day trip to Western Ukraine. Helped treat dozens of civilians and soldiers injured on the front lines of the war with Russia. Dr. Moscatello said he saw his first day how severe the injuries are.
A stretcher wheeled out of the elevator, and there was a young man on the stretcher with a black patch over his right eye, and his left foot was missing. And you don't see things like that every day in the United States.
His decades of experience treating ear, nose, and throat problems helped him treat blast and gunshot victims.
And there were a large number of eye injuries, facial injuries, nasal injuries. We treated 3 patients that had parts of their jaw destroyed by the injuries, gunshot wounds.
A sobering experience that's left Dr. Moscatello with this outlook on war.
Take away what I knew already, that war is something to be avoided at all costs.
And as the war continues in Ukraine, so does the need for medical care. That's why Dr. Moscatello is planning to return to the country for another medical mission this spring. In Valhalla, Nadia Galindo, News 12.
Dr. Moscatello was honored with the Westchester Magazine 2023 Healthcare's Heroes Editor's Humanitarian Award. And Dr. Moscatello, today we express our gratitude and admiration to you for a lifetime of clinical excellence and leadership, and it's really inspiring us to understand that we're all citizens of the same world. Dr. Moscatello.
I'd like to thank you all, thank the Trauma Symposium coordinators for this honor. I think I owe it all to my experience here at Westchester Medical Center. When I came, my experience in trauma was very limited, and over the 37 years that I've been here, I've been exposed to more trauma than I could have imagined when I first started. And I always had an interest in providing care for people. That's why most of us went into medicine. And there's no place better to provide care in these foreign situations where the citizens don't have access to the same health care that we have here. And when political or natural circumstances cause great destruction. For me, it's a no-brainer to go and to serve the people that would not have been able to have the care that we've provided for them without us going to the country they were living in. And again, I'd like to thank everybody for this. And my only thing is we went into medicine because we wanted to make a difference. And if any of you have any desire at all, there are many organizations that you could contact where you can spend time, whether you're an administrator, a health professional. The need is there, and I would recommend that you investigate it, because the reward is really something that you can't imagine until you see the impact that you can have. Once again, thank you very much.
And now, it's really my great honor to introduce and welcome our distinguished visiting professor, Dr. John Holcomb. Dr. Holcomb, prior to his current tenure as professor in the Division of Trauma and Acute Care Surgery at the University of Alabama at Birmingham, served for 23 years in the United States Army. He has served in multiple combat deployments, including in Mogadishu, Somalia, where he was part of the surgical team that delivered 48-hour nonstop care to soldiers during the battle that inspired the book and film Black Hawk Down. From 2002 until his retirement from the military in 2008, he served as both commander of the United States Army Institute of Surgical Research and trauma consultant to the Surgeon General. Because of his leadership, the military began issuing life-saving tourniquets to every member of the United States Armed Forces deployed in combat zones. Dr. Holcomb initiated the use of hemostatic dressings in place of gauze and introduced major advances in resuscitation. For these initiatives, he was the recipient of 3 United States Army Greatest Invention Awards. His achievements and dedication to servicemen and women have earned him numerous military honors, including the Honorary Medal for Combat Surgical Care, the Army's Development Achievement Award for Leadership and Excellence, and the United States Special Forces Command Medal. In 2008, Dr. Holcomb received the American Heart Association's Lifetime Achievement Award in Trauma Resuscitation Science and the American College of Surgeons Committee on Trauma Service Award for outstanding scientific contributions to the surgery of trauma and dedication to the care of the wounded warriors. Dr. Holcomb has had a prolific academic career as he reviews papers for more than 35 journals and has published more than 690 peer-reviewed articles. Indeed, his contributions to the physiology of resuscitation and the need for balanced resuscitation in whole blood have revolutionized the field of trauma. More recently, Dr. Holcomb has made multiple trips to the Ukraine with the Global Surgical and Medical Support Group, where he's provided individual patient care in the operating room, the ICU, and hospital floors while providing valuable training to local health professionals. Dr. Holcomb, your contributions to military and civilian medicine, surgery, and trauma are truly inspiring and establish a legacy of innovation and service for generations to come across the globe. We are honored and grateful to have you with us today as our distinguished visiting professor. We know with the recent calamity in Houston, Texas, and the state of Texas, you're unable to join us live and in person today, but your presence is palpable as you join us virtually from Texas. Thank you so much.
All right, thank you, Dr. Holcomb. I'm going to be sharing your presentation as we continue our event today.
All right, Katie, thank you very much. You guys can see the screen. If you go to the next slide, please.
Yes.
All right, so it's not moving on my side, but that's okay, because I can still see it. Next slide. So what I'd like to do, number one, go back. Yeah, dadgummit. Yeah, I'd like to tell a story today. And what I really want to do, let's see, go back, I'm sorry about this. Go back 2 slides, Katie. Huh. Really interesting. Yeah, it's, I'm sorry I couldn't be there in person. Zoom is a relatively inadequate substitute. And let's see, we're going to make this happen, right? Next slide, Katie. Next. Yeah, number one, thank you for the opportunity. We did have a hurricane here 2 days ago, and 3 million people were out of power. Same number were out of internet access. There's only 1 million people in Houston without power and internet today. So we'll try to stumble our way through this a little bit. I did have 2 reservations that got canceled on airplanes, 2 different airplanes at 2 different airports. I really did try to get to y'all's location. What we'll do today is tell a story using blood. I'm going to weave together 6 themes over the next couple minutes or so. Next slide. But it's not really about blood, although we'll talk a lot about it. It's what you do to make the world a better place. Kind of like what Dr. Muscatello was saying. You know, it's stop for a minute and think, what do you do? Now, the junior residents take care of the patients, do H&Ps, medical students used to start IVs and draw blood. Everybody does something, and it doesn't need to be life-changing to help the world be a better place. Next slide. History is what we'll talk about first. Next slide. So the story of blood is actually really interesting. And I think medical history, maybe it's something that old people get interested in. I honestly didn't know much about medical history, especially military medical history, for a large part of my career, but I've spent more time in it in the last 10 years. This paper by Sam Carmichael is pretty interesting because it goes back and talks about blood transfusion back to 1667 as a treatment for mental illness with predictably poor results. I think the wife gave cow blood to her husband, and the husband didn't do well. And we move forward really into World War I, where blood banking became normal. And if you look at the evolution of resuscitation over time, admittedly this is US-centric, for 127 of the last 160 years, blood's been the primary resuscitation fluid, not crystalloid. And honestly, over the last decade or so, 15 years, we're moving back to just that. I hope by the end of 2024, we'll have dry plasma and whole blood again. We'll talk about that. Next slide. So the first transfusion I can find in the United States is from the Civil War. It was Private Gross, who had a gunshot wound to his right leg, had an amputation for sepsis, like many of them did. He was transfused a total of 60 milliliters from a strong, healthy German. He, uh, the transfusionist was a surgeon, as all transfusionists were at that time, who became the first chair of surgery and the dean at UAMS, which, by the way, is where I went to medical school. Next slide. World War I was really the first war where lots of blood was given. Femur fractures were splinted, laparotomy became common, and these were facilitated by blood transfusions. And so hundreds of thousands of units of blood were given. Next slide. Colonel Pete Churchill is an interesting guy from World War II, wrote this book, Surgeon to Soldiers. You can't find this book now. It's about $800, but it's not in print. We are reprinting this and will be released at the American College of Surgeons meeting in a couple months. Next slide. Pete Churchill was interesting in that he worked in the hospitals, came from Boston, worked in the hospitals in North Africa, would go visit the British hospitals. They had remembered whole blood from World War I. The US forces had forgotten about whole blood. And the British guys were living and they were pink, and the US soldiers were dying pale. And he wrote a bunch of memos. If there are military folks in the audience, the memos went up to the Surgeon General's office. They were ignored about the benefits of whole blood. And so he grabbed a passing by New York Times reporter, went outside the chain of command, totally against the rules, talked about whole blood and its benefits to the soldiers. And lo and behold, a couple weeks later, whole blood was available to the US forces as well. Next slide. This paper is described as arguably the single most important paper to come out of World War II, written by Dr. Churchill, published in Annals of Surgery near the end of the war, and talks about wound care, echelons of care, talks about Dakin solution, leaving wounds open, and also about whole blood and dried plasma and how important they are. Not one or the other, but both. Next slide. By the end of World War II, that dried plasma and whole blood was the way soldiers were resuscitated, dried plasma on the pre-hospital and whole blood in the hospital. Remember this, please, as we go forward. And now I'm going to move forward to pretty quickly to the 1960s. This is where we got confused with crystalloid, as led by Shires, Carrico, and others, real giants of resuscitation. The problem is they use controlled hemorrhage studies, stopcock studies, where the animals were bled through stopcocks. And when you do that, you can give crystalloid, and those dogs did just fine. Next slide. But if you do that to people, whether they be children or adults, in my opinion, they don't do well. And so at a time where Carrico and Shires were talking about crystalloid and components, at the same time where this is happening, and this is not causal, but it's certainly temporally related, the folks in Vietnam started talking about Da Nang lung, otherwise known as ARDS. At the beginning of the 20-year war in Vietnam, whole blood was used, Da Nang lung or ARDS was not described, and by the end, components and crystalloid were given. If you read the Carrico and Cannizzaro and Shires paper from 1976, this is their last paper where they really talk clinically about what to do. What they say is give a little bit of lactated ringers, 1 to 2 liters, over 45 minutes, which will be slow today because we have these rapid infusers, and then get your whole blood ready. That's what the leaders of resuscitation back in the 60s and 70s said. Next slide. Now, if you move forward into the late 80s and early 90s, and this is when I graduated medical school in 85, and so I participated actually in this study led by Art Fleming and Shoemaker when they were in LA together. We used to give 10, 20 liters of crystalloid to these patients to drive them to a supernormal resuscitation. You can't even fathom how much we hurt our patients by doing this. The supernormal resuscitation, again, a paper that I was participated in as a fellow, published in 2003. So the supernormal resuscitation certainly did drive the cardiac output. The old people in the room remember this. But we also created intra-abdominal hypertension, abdominal compartment syndrome, multi-organ failure, and death. We created these injuries in our patients, and by an iatrogenic resuscitation injury created this. This was pretty common. 14 units of red cells, a little bit of FFP, no platelets, no cryo, and 25 liters of crystalloids. The patient I took care of, I resuscitated and took care of in 2006, civilian-wise. Next slide. So you move forward to another decade later, and we started doing studies looking at resuscitation. And what we found was that this inflammatory response and ARDS and multi-organ failure was much closely related, was much more related to the crystalloid rather than the blood products. If you look at all of the fluids that the patients got, every 500 milliliters of crystalloid infused during the first 6 hours was associated with a 9% increase in ARDS. Blood products during that same time period were not associated with a risk for lung injury. And so we coined this term, which has not caught on, I think it's pretty cool, called CRALI, crystalloid-related acute lung injury rather than TRALI. Next slide. Yeah. The kind of the bottom line here is that the animal research using controlled hemorrhage models led to massive crystalloid resuscitation and an iatrogenic resuscitation injury. They didn't use uncontrolled hemorrhage models. These animals have to have the ability to rebleed, pop the clot, and develop these resuscitation-related injuries. You can't just look at the first 30 minutes or to 1 hour. And this led to incredible increased death and significant morbidity in our patients. Next slide. So the history is really important. You got to understand the evolution of the issue, why it happened, know the methods, read the papers, and understand the science. Experience. Next slide. Now, as has been mentioned, I graduated residency in 1993. There were very few trauma fellowships at that time. And so I went to Fort Bragg, North Carolina, and deployed in support of with the Joint Special Operations Command and support of Rangers, Delta, and SEALs. And in 1993, we found ourselves in Somalia. And from a blood point of view, we had a walking blood bank. Now, I will tell you that I thought we were all going to go to jail. I'd never heard of this before. The walking blood bank was suggested by Dr. Denver Perkins, an anesthesiologist who had been a infantry guy in Vietnam and had deployed in the first Gulf War, and so knew about this. Next slide. A third of our hospital laid down, gave whole blood, and got back and went back to work. That was in 1993. We then subsequently studied this, thought about it, came home and did animal studies. And then we go to war in 2001, 2003, and really deployed the walking blood bank, deployed plasma first, deployed balanced resuscitation, and studied the results. Next slide. This culminated in a guideline through the Joint Trauma System published in 2014. Well, we recommended that whole blood be the #1 recommended fluid for pre-hospital resuscitation. And the balanced resuscitation, well, that's with whole blood or components, be recommended for the hospital. 2014. Remember these papers as well. What we recommended at the time was whole blood. If you can't, this is pre-hospital. If you can't do that, do a balanced resuscitation. Of course, doing platelets is difficult pre-hospital, but plasma and red cells are less difficult. Plasma alone, red cells alone, and we deleted any clear fluid, hexten, crystalloid, lactate inhibitors, any of them. Those guidelines have since been updated. The first one was published in 2004, and they still exist on the Joint Trauma System clinical practice guidelines. The last one was updated just recently. You can check these out as well. Experience on the battlefield, and for the non-military folks in the room, which I think is probably the majority, I would say experience in the ED and the OR and the ICU is really important for leaders. Leaders can't just quit taking care of patients. They have to, yet, I don't take care of as many patients. I don't work as many hours as I used to, but I still take care of patients. And I think it's important for our leaders, no matter where they are, to continue to do that. They understand the problems. They can bring them. They can provide solutions, whether it be administrative or research problems, and solve problems for us that are working, for those that are working full time. Next slide. Next slide. I just put up some fun slides. This is the OR schedule in Baghdad in 2006. Notice I had a really good haircut at the time. And you can't read it, but every one of those patients has a penetrating gunshot wound and needs a laparotomy. I'm on call. I'm on first call that day. That's the reason I'm smiling. Next slide. As been mentioned, and I'll talk about Ukraine at the conclusion of this talk, I had the opportunity to go to Ukraine 4 times in the last couple of years. I'll be back again in a couple of months. These guys are truly fighting for their homeland. And I personally think we should do everything we can to help them. Couldn't agree more with what Dr. Muscatello said. And by the way, congratulations on your award. Next slide. Just again, it's important for us to have clinical experience, no matter who we are. And I'm operating with 2 graduating fellows. This is the last day of their fellowship last year. And so we took this picture as we take care of a fireman with a high velocity gunshot wound in Birmingham, Alabama. Next slide. That experience is really important. We've talked about leaders must continue to take care of patients, albeit maybe not as often. But combining clinical experience with the research opportunities is really, really an amazing opportunity where you can see the problems, take it to the lab, devise potential solutions, and then bring it back to the clinic. And then do that over and over and over again. Next slide. Next slide. Yeah. So we all have a reason to do research. Has been mentioned. I had the opportunity to deploy as a young surgeon. And there was one patient who died or I couldn't stop his bleeding in 1993. And we all have these patients that we remember. I can tell you everything about this patient. I can tell you everything about what we did, in hindsight, what we should have done, and has driven the way my research programs have progressed over the years. Next slide. This is me writing a paper on a cargo plane. That's a Humvee parked in front of me. I'm in a sling seat in a cargo plane writing a paper. So you don't need dedicated research time to make progress. It certainly is nice. But when you're first starting out, you usually do these things in between cases, or in my case, on deployments. Next slide. Find your area. In your area. I need to fix that slide. Find your area. When you first start out, you're going to work in a lot of different areas. I kind of coalesced my areas down to hemorrhage control and resuscitation, divided into compressible and non-compressible, tourniquets and hemostatic dressings, and then IV drugs, blood, and cavitary foams. This slide actually was made about 20 years ago. And then do animal studies. Large animal studies in mice and rats and pigs are really helpful to help tone down and get rid of bad ideas and then progress on the good ideas. My lab started in 1994 in El Paso and has progressed on. I don't have a lab anymore. I had an endothelial biology lab and a large animal lab, and I help folks with labs now. Next slide. As was mentioned, I had the opportunity to command the Institute of Surgical Research for 6 years. We did hundreds of animal studies and very little randomized human studies. In hindsight, which of course is always 20/20, I wish we'd done more humans and fewer pigs. We did do some interesting things. This is a rat foam study. Would fibrinogen foam stop bleeding from a major rat liver injury? And the answer is yes. Just spraying foam on helped significantly decrease blood loss. And hopefully, in this abdominal hemorrhage, we'll have better ways to stop abdominal hemorrhage pre-hospital. We did a lot of preclinical work. With Jill Sundin, who's retired, Mike Dubik, who has died, and Charlie Wade, who's retired. I'm the only one still working here. I guess I'm on the way to retirement. But the blood pressure at which rebleeding occurs, uncontrolled hemorrhage compared to controlled hemorrhage, and then resuscitation with plasma. So that paper, the last paper, is probably pretty important for where we are today and where we're going to go. Next slide. We did deploy research teams into Iraq and Afghanistan the first time since World War II, since Vietnam. And those groups did a bunch of work and led to a lot of really nice papers, and more importantly, change in practice on the battlefield that has come back and helped inform and change practice in the civilian community. Next slide. I strongly, this section of the talk is longer than any other section. I strongly feel that trauma systems must do research. Systems must do research and provide that research. It doesn't all need to be really highfalutin NIH funded stuff, but the opportunity and the ability to do research across your system makes your system better. Next slide. I put this slide together a number of years ago, and if you work in only one area of the trauma system, you're going to have minimal impact on outcomes. But if you work across all areas or multiple areas here, the impact will be much greater. And we know that from kind of a systems research, folks who work in systems. It's always better to work in multiple areas. Next slide. Keep going. Yeah, I'm going to move forward here. Some of these slides were hidden when it's in presentation mode. Next slide. We did come up with this idea of balanced resuscitation in Iraq. Matt Borgman published this paper. He was a pediatric critical care fellow at the time. And next slide. And what Matt showed in this paper was that the patients, combat casualties who got more of a balanced resuscitation did better than the ones who got unbalanced. Remember, back in 2003, 1 to 8, 1 to 4 was pretty normal resuscitation of red cells to plasma. And you can see the markedly different rate of survival. Now, when you look at this slide, it's unclear if the patients, because it's not randomized, did they live long enough to get a balanced resuscitation, or did they live because they got a balanced resuscitation? Next slide. It was really an important question with that survival bias. We then wrote a commentary, and Dr. Pruitt published this in the Journal of Trauma. But you can notice there's a bunch of authors. I always like to do that when I have no data to discuss. So this was an idea commentary. And the idea was that damage control resuscitation is a different way to resuscitate these patients who need blood products and are profoundly hypotensive. We had very little data at that time. Next slide. And what we wrote was that DCR components start and stop with stopping bleeding, right? You can do a bunch of stuff in between, but if you don't stop bleeding, which is what we discussed this morning, then all of this stuff really, I think, becomes much less important. It's important. It is important how we resuscitate and minimize crystalloid and give plasma early and platelets, but you have to stop the bleeding as well. Next slide. Brian Cotton wrote about this. Next slide. And so did Par Johansson. Now, what was interesting is Par is an anesthesiologist, became a blood banker, and he works in Copenhagen. At the same time we were writing about this balanced resuscitation in combat casualties in Iraq, he's writing about it in ruptured aneurysm patients in Copenhagen. I find that really interesting. If around on different sides of the world in two different populations of patients, both bleeding a lot, but you come to the same conclusion that we should give less crystalloid, platelets early, and balanced resuscitation, there's probably something to the idea. Par has since become a collaborator on multiple projects. And this is the paper that Chris Snyder wrote in 2009, talking about our survival bias, and did they live long enough to get the treatment, or did they live because they got the treatment? It's an important concept. Most of our trauma papers and studies suffer from this issue because very few are randomized. Next slide. Zaid wrote this paper, again, talking about time. And what we did is just move plasma and red cells, especially plasma, from the blood bank to the ED, and it was associated with a marked improvement in survival. Although not randomized, this finding has been borne out in multiple papers since. So we talked earlier about, go back a slide, please. We talked earlier about plasma not being in your ED. I really think you should put liquid plasma there. It will markedly improve your outcome of patients. Next slide. We then did a randomized study published in 2015 called PROPER, where we compared two different ratios. Next slide. Next slide. Yeah, and what we showed is there was a negative study, no difference in 24-hour and 30-day Kaplan-Meiers, no difference in this study. Yet, when we asked our statisticians, and really when you ask the world, which group would you rather be in, I think the world and our statisticians said they'd rather be in the group that got 1:1:1. Next slide. It's hard to see this, but what we did show was a significant decrease in exsanguination, although there wasn't a difference in 24-hour and 30-day mortality. There were fewer patients that exsanguinated, which of course biologically was the goal of a more balanced resuscitation. Next slide. The time to hemostasis was the same in both groups, but again, the percent that received hemostasis was substantially improved. Next slide. And there was a significant difference, a post hoc evaluation there was a significant difference in mortality at 3 hours, which of course is around the time of hemorrhagic death, 3 to 6 hours. Next slide. No difference in any complication, 23 pre-specified complications, no difference. Next slide. Subsequently, there have been lots of papers, hundreds of papers published on this balanced resuscitation thing, both single center and multi-center funded by the DoD, NIH, and around the world. Next slide. Next slide. I do want to talk about this slide for a minute. It's a little bit off topic, but I think the real bloody vicious cycle that we struggle with is that there is a lack of consistent federal funding for trauma. Because of that, and the funding is not consistent with the societal impact. There are a few investigators interested in injury because you got to go with the funding, kind of like that bank robber story. Because of that, we have a lack of high quality data to guide what we do. And because of that low quality data, it's largely published in low impact journals. Very rarely do you see a trauma paper in JAMA or New England Journal of Medicine. And so we end up with tradition-driven suboptimal clinical care. And to me, that's the real bloody vicious cycle. Next slide. The observational study of moving blood products pre-hospital was really pushed forward by Stacy Shackelford, published in JAMA. Observational study, and you can see the Kaplan-Meiers here. These are combat casualties. The blood products need to be given with 15 to 20 minutes of injury to make a difference. Next slide. And what I think is probably one of the most important papers published in the trauma literature in the last 20 or 30 years, if not in my lifetime, is New England Journal of Medicine. Jason Sperry and his group. The Kaplan-Meier doesn't look all that impressive, but what he showed was a 23 to 33% 30-day survival in difference by giving blood products pre-hospital. The difference occurred at 3 hours, just like we saw in Proper and Stacy saw in her combat casualties. And this includes TBI patients. There is nothing that I know, nothing that I know that has a 10% absolute difference in survival. Next slide. Just one slide, if you will, on mechanism. Why does this happen? And I mentioned this earlier. In the top left hand there is a venule that has the glycocalyx intact. You put that rat into shock, and the glycocalyx is stripped off, and the adhesion bodies become separated, and the paracellular contraction, and fluid goes from the extravascular to intravascular space. Now, if you plug an IV in and give crystalloid, fluid goes from the intravascular to the extravascular space, and you get edema throughout the whole body. That's if you resuscitate with crystalloid. If you resuscitate with plasma, then that reverses that paracellular contraction, and you get reconstitution of the glycocalyx, albeit not normal. It's the bottom right-hand side there, but you significantly decrease edema. There's a lot of preclinical data that supports everything I just said there. And that is the reason why personally I give plasma first. I use it as a drug to repair the glycocalyx, to prevent edema, whether that's in burn patients, TBI patients, or hemorrhagic shock patients. What's interesting, and we'll not talk about today, is I think it probably would help sepsis patients as well. Next slide. Next slide. Next. Yeah, like I said earlier, lots of non-randomized whole blood papers. There are 2 randomized studies so far, one by Brian Cotton using a modified whole blood, because of the filter to filter out the white cells, also filtered out the platelets. And Frank Guyette from Pittsburgh using a low titer O whole blood where the platelets were still functional. Next slide. There are two ongoing whole blood trials pre-hospital. One is Troop and the other one is Lights. One is in the hospital and one is pre-hospital by John Jansen at UAB and Jason Sperry at Pittsburgh. Next slide. I really think for us in the trauma world, the DoD, the NIH, and BARDA should fund more clinical research. I know they fund lots of animals, and I have done lots of animals, mites, rats, cell culture, etc. But we really need to do a large series of clinical studies. Next slide. We start to wrap up here, and I'm going to move this part quickly. Dissemination, implementation, and policy. So you can't just keep these results in the ivory tower. Next slide. You got to get them out. And the military has done a pretty good job of this, the Joint Trauma System. Next slide. Next. Yeah. And have published many examples of this, how to do it, explaining why to use whole blood, the history of whole blood, the economics, and the logistics. Next slide. The military and civilian adoption is spreading. Next slide. And this military-civilian collaboration was described by this IOM report, National Academy of Science, changed the name while we're there, but talking about 0 preventable deaths after injury, published in 2016. Next slide. Next slide. And next, yeah. Next. This is probably one of the better low titer O whole blood studies that's published right now. It's been out now for a little while, but what Hazelden did is look at 1,600 patients compared to component therapy with 400 patients in an observational study, and the whole blood patients were less likely to experience bleeding complications and much more likely, less likely to die. Next slide. Next slide. Now, pre-hospital whole blood and hospital whole blood is really interesting. There are about 50% of level 1 and 2 trauma centers in TQIP have whole blood available in their ED or OR, 50% of level 1 and 2 in TQIP. But only about 1 to 2% it's available pre-hospital. It's kind of a conundrum. Next slide. It is the standard of care in the deployed setting, pre-hospital transfusion, rarely done in civilian pre-hospital setting. And I think it's largely because you can't bill for pre-hospital blood. And I think we need a regulatory change there. Next slide. We've spent a fair amount of time with the economics and logistics. We're talking to CMS and the federal government about this and have written quite a bit now about the why pre-hospital whole blood or pre-hospital blood products, just in general, are not more widely used since there's such overwhelming data supporting their use. Next slide. This is Randy Schaefer is a retired Army nurse colonel and has really gotten on this, has written a really nice paper about this roadmap to success. And what she writes is that the limitation is primarily financial. There's no longer a logistics or safety issue with blood products. It's primarily financial. Medics don't get reimbursed. Pre-hospital agencies don't get reimbursed for giving blood. Next slide. There is lots of how to do it, lots of dissemination papers. Again, no longer a problem. It was a problem many years ago, but not now. Next slide. I took this slide and I put this, I downloaded off the internet. This is toilet paper, if you guys remember during COVID. I'm sure you do. Imagine this is your blood bank. Yeah, what are you going to do if there's no blood on the shelf in the blood bank? Next slide. What the military has done, as I said earlier, from every war we've been in, is implement the walking blood bank. And I think we should have a similar capability in the civilian world. Next slide. Next slide. So I don't know if you all have many military-civilian partnerships in the New York area. I'm sorry, I don't know that. I know that there is in New Jersey and other places in the Northeast. Remember, I'm from Texas, so you guys all kind of look alike up there. But this military-civilian partnerships are really important for training for blood. And and we say that because there's lots of lessons learned on the battlefield that come back to the civilian world, but in between wars, the civilians are the repository of this knowledge so that the military doesn't lose that knowledge as we go to the next war. Next slide. Next slide. Like I said, it's civilian trauma centers are increasing their use of whole blood. And it's important for our military folks, docs, nurses, medics, all of them, technicians, blood bankers. They shouldn't see pre-hospital blood and blood products for the first time on the battlefield. That's not optimal. Next slide. It's important to train as close as possible to how we fight, and these military teams need to do that. Next slide. The worldwide impact as we get ready to close here. Next slide. There is a international research agenda that's been discussed by multiple folks around the world and includes whole blood, both pre-hospital and in the hospital. Next slide. There is an ongoing UK study. Next slide. And an ongoing French study as well. Next slide. Yeah, I'm going to close and talk about Ukraine for just a second. As you all know, in February 22, Ukraine was invaded again by the Russian terrorist state. Next slide. About 2 months later, I had the opportunity to go to Ukraine and not only talk about some of these issues, but also round the floors, round the ICU, and then operate. Next slide, with Ukrainian colleagues. 2 weeks after discussing blood products and whole blood specifically, they put whole blood in their ED. 2 weeks. In my hospital many years ago, it took 2.5 years. These guys did it in 2 weeks. Next slide. They approved pre-hospital whole blood, in-hospital whole blood, TXA, balanced resuscitation, walking blood bank, and all the JTS CPGs. In Ukraine, to make these changes requires a change by their Congress, and this has to be changed in law. And they did this pretty quickly. Next slide. In the ED, like I said, in June of 22, in one hospital, these guys have now given over 1,000 units of whole blood in one hospital, and 4 units are using dried plasma and whole blood. Remember exactly where U.S. forces ended up in World War II. Next slide. In February, I had the opportunity to meet the colonel who is their equivalent of the trauma consultants for the Surgeon General, Konstantin Homanuk, and we spent time together. We broke bread together. We drank vodka together and talked about blood and many other things. Next slide. The worldwide impact of blood products is pretty impressive. To me, it's impressive that this concept has moved from war into the civilian space and become the standard care. And again, really important for the military teams that are in that mil-civ collaboration to learn of this in the civilian world so they can take it to the battlefield the next time and move it forward. Next slide. In summary, we used whole blood for the first time since Vietnam in 1993. The DoD and NIH funded a program of blood research and has changed clinical practice around the world. Those people who wrote the RFPs are the ones really that deserve the credit because they wrote the RFPs. All we did was respond. And, you know, I just would close. I know I talked a lot about blood, but I hope that it came through that what we do, right, in trauma systems really does matter. Whether you do clinical research, where you're a non-medical leader, as long as we keep a laser focus on improving outcomes, we will help our patients not only in our center, but around the world. Next slide. It is important, this is for the students in the audience, the residents and students, it's important to challenge dogma. One of my favorite books from college, high school actually, was Don Quixote, who challenged dogma. Now, he did it respectfully. It's really good when you can do it with data. It's upsetting to the status quo folks. They don't like change, right? Whoever they are. But it's the only way progress is made, especially during interwar periods, and we must be ready for the next war. Next slide. Next slide. Next slide. Thank you very much.
We can see you, and that, really an inspiring talk. Thank you for sharing that knowledge. Thank you for inspiring us for what you've done in terms of your service to our country and certainly across the globe, but also in helping us understand how to do trauma better over the last several decades. And your lessons stick with us today, and we continue to learn from your work, so we really appreciate it. Now, if the audience has any questions, I'm sure Dr. Holcomb would be happy to entertain them. But Dr. Holcomb, you and I have made an agreement that I do have a plaque to commemorate your virtual visit with us today and your wonderful talk, but it will only be given to you in person so that we too have an opportunity to have vodka together. Or
Yeah,
rather,
happy to do that. And again, I do want to, Zoom is a poor substitute for in-person. I did try. I do have 2 canceled boarding passes from 2 different airports and 2 different airlines trying to get up there. So I apologize
we
to
understand
the
Texas
group.
has been through a lot. I can also assure you that New York and New Jersey are 2 different states. But thank you so much again, and we look forward to welcoming you in person very, very soon. For the audience, thanks for your attention, and now we'll enter a short break before really again, it's hard to kind of top what we've heard in the last couple of hours, but if you can believe it, we're going to try, and that's with our John Savino visiting professor David Livingston, as well as our trauma survivors and an honoree. So we'll take a short break and reconvene in this room. Thank you.
Dr. Holcomb, if you have a second, I just wanted to talk to you real quick.
Yeah,
No,
sure.
I'll just wait till everyone clears the room. Or I'll give you a call on the cell phone, if that works.
Thanks. Yep.
I was trying to announce, I was trying to say we screwed up with the questions, but nobody's saying. I'm just going to tell them just to use the YouTube links now.
Yep.
And I'll just turn off.
If I could ask everybody to, again, grab a seat, and we can get started with the afternoon's concluding portion of this wonderful symposium. So please grab a seat, make yourself comfortable. So now, as we head into this afternoon portion, this is really a tremendous personal privilege of mine because Tony Policastro is a partner and a good friend of mine, and it's my privilege to welcome him as our 2024 WMC Health Trauma Lifetime of Service awardee. Tony Policastro has served the patients of Westchester Medical Center for 39 years as a trauma surgeon, a critical care physician, a general surgeon, and a person that everybody seeks in their time of need. After spending his formative years in Queens and Long Island, Dr. Policastro graduated from Holy Trinity High School, where he was an all-county baseball player. And perhaps his most significant life accomplishment came long before he ever donned a white coat. At the age of 16, Tony met his lovely wife, Barbara, who's here with us today. In 1985, Dr. Policastro began his surgical career here at Westchester Medical Center and New York Medical College, where he trained under the late Dr. Louis Del Guercio, a founding member of the Society of Critical Care Medicine. His career was further shaped and transformed by the mentorship of none other than Dr. John A. Savino, for whom our visiting professorship at this very symposium is named. And at this time, let's see a timeline of his life and career that's captured in this video.
Hi, my name's Stephanie Kennedy. It is my honor to be here to honor Dr. Policastro for his 40 years of fabulous service here at Westchester Medical Center. I met Dr. Policastro many, many years ago as a new nurse in Unit D. He was instantly approachable, kind. He was eager to teach you anything that he was doing in the room. Dr. Policastro was always so good with the families. He always went the extra mile to speak to them and make sure they were comfortable. He made sure that he remembered the human part of medicine. The families were always grateful that he was their doctor. He did surgeries that other people wouldn't even try to do at times. And still to this day, many of the patients and families who are grateful keep in touch with him.
Hi, my name is Kathleen Dwy, and I'm one of the assistant nurse managers of the trauma ICU. Dr. Policastro was the first attending that I ever met when I was a student in the TICU 19 years ago. He taught me everything that I know about open abdomens and hot bellies. He stood there and went over everything with me when I knew nothing at all. He always made me feel like I could ask him anything, and he was always there for me. As I continued my career as a nurse, coming back to work in the TICU, he's always been there whenever we needed anything. If there was ever a family that needed something, I knew I could always go get him, that he would come and help them understand what was going on. He's always been there for the nurses. Anytime they needed help, anytime they needed direction, he would always come to the bedside and help us understand. He would educate the new nurses when we asked him to. He's always been approachable, a kind individual, and someone that I've always enjoyed working with.
You know, Dr. Policastro trained in an era where there was really very little specialization within the field of surgery. Trauma, breast, colon, cancer, head and neck. You know, to this day, he really exemplifies that rare skill of being able to provide such a diverse set of masterful skills. So for 39 years, Dr. Policastro has dedicated his life to the care of patients and families, advocacy for nurses and first responders, and for the education of multiple generations of surgeons. And for the last decade of his career, it's been my honor to call him my partner and my lifelong dear friend. So Tony, thank you for your lifetime of service to WMC Health and to the care of the injured patient, and congratulations to you and your family.
So this is going to come off the cuff because I wasn't sure that I was going to say anything today. So listen, I am the luckiest guy in the world. Very young, I fell in love with human anatomy from an encyclopedia, and I figured that's the job I need to do. And it was a challenge to get there at times, but unbelievably, you know, I got to do exactly what I wanted to do. And I think it's such a great gift, and so many people don't get the chance to do what they really want to do. I tried to do it with 100%, 100% of the time, because I think, you know, that could have been somebody taking care of my mother, my brother, my wife. My wife is a saint. Okay, I mean, in the world I lived in the very beginning, nobody was concerned about how many hours I spent in a hospital. And she raised two unbelievably great children, and she still had time for me when I came home at 3 in the morning or whatever it was. So she was a great strength, and I couldn't have had a better life. And yeah, I know that, you know, medicine has changed, and I think in some respects that it is probably better in the end that people who do a lot of simple things or parts of surgery, what I did as a general surgeon, it's probably better that they do a lot of them and people will get better outcomes. I can't thank the nurses and all the other people that function, you know, the people who worked on the ventilators, the people who, you know, set up the TPN, the nutritionists, and the team was just a great team to work with. I never had any problems with
people not wanting to do the right thing. And I was happy to educate and get educated along the way as well. And I can't thank all the people that helped me along the way: John Savino, Lou Del Garcio, Tom Cherubona, and a lot of even the residents who got me balanced at times, because I get a little intense at times. That's what surgeons do. I mean, when you feel like there's an issue or a problem, you don't want to. I was taught that you had to put the fire out because it only gets bigger. So I want to thank all of you here today. All those are people that supported me along the way, and I'm really grateful for this opportunity to say thank you.
And now, you know, it's quite fitting that we're able to introduce with real privilege our 2024 John A. Savino Visiting Trauma Professor. Dr. David Livingston, aside from what I'm about to say to introduce him in terms of his career and his contributions, his main focus, and even the title of his talk today, focuses on trauma survivorship. So how fitting that after his talk, we will hear from many that are sitting in the front rows of this auditorium today. They're true heroes of any story that has the word trauma in it, the patients and their families that know firsthand what it means to be a trauma survivor. But for now, I'd like to begin by, again, welcoming Dr. Livingston and thanking him for joining us today. Dr. David Livingston is a native of upstate New York, having earned his undergraduate degree at Rensselaer Polytechnic Institute and his Doctor of Medicine degree at Albany Medical College. After completing his training at general surgery at New York University and his fellowship in trauma at the University of Louisville, Dr. Livingston has led the renowned trauma program at Rutgers, New Jersey Medical School in Newark, New Jersey for 35 years. At Newark, Dr. Livingston serves as the Emeritus Professor of Surgery and has held a number of trauma and surgical leadership positions as he built a nationally renowned trauma program that has been a beacon of clinical excellence and scientific contributions while training scores of trauma surgeons and future leaders, many of whom are in the audience today. Dr. Livingston has served as past president of the American Association for the Surgery of Trauma, the Western Trauma Association, and has held leadership positions in several major national and international trauma surgical societies. He has authored more than 300 peer-reviewed publications and book chapters and has delivered numerous regional, national, and international talks. In addition to his extensive international surgical volunteerism across the continents of South America, Africa, and Asia, Dr. Livingston has been honored with prestigious awards and commendations from the American College of Surgeons, the Association of Women Surgeons, the FBI, and the state of New Jersey. It is also important to note that among Dr. Livingston's most significant contributions lies his advocacy of trauma survivorship. In honor of all of our patients, it is therefore my great pleasure to thank you, Dr. Livingston, for your presence today, for your leadership, and for inspiring generations of trauma surgeons. Dr. Livingston.
Wow. You know, after these introductions, you just go, who is that guy? I can't thank the Westchester Medical Center, Dr. Prabhakaran, Dr. Salvino, everyone I met last night. Such a warm and wonderful welcome up here. And I think there has been a theme through the symposium about why we do this and what we do. And I hope I will somewhat add to this. I am so honored to be giving this lecture in front of Dr. Savino, who I've known on and off for the last 30 years. And Really, it's such a great honor. I've also, I'll be honest with you, I've never given this talk in front of so many trauma survivors. So I'm kind of petrified about this part. I've given this talk in various to in front of 1,000 people, literally, and because I don't know, maybe I have got it completely wrong. I don't think so, but please tell me, because we do a lot of talking, and unfortunately, as you hear, we don't listen a lot. Yeah, so I'm emeritus professor at Rutgers. I now am starting, I have a part-time gig actually at the University of Colorado where I'm going to try to develop survivorship out there. That's actually where I am part-time at this point, since I'm sort of semi-retired or not. I don't know, I'm busier now than I was when I was taking trauma calls, so I don't understand. I can't thank these funders enough, especially the Healthcare Foundation of New Jersey. I have to give them props. They're the ones who took my idea and made it a reality with a very small grant, actually, and I managed to shepherd the money, and they came and did it again, and God bless them, and then the other people. And in retrospect, you'll hear, I've always thought about this as part of a long history of trauma care, and why I didn't do it is another reason. So I want to talk a little bit about trauma recovery, what that even means, and please, at the end, you can yell at me for getting it all wrong. Go for it. I've been yelled at plenty by probably a lot worse people than you. But my involvement and why I thought it's important, and sort of a little bit of history of trauma outcomes, somewhat to parallel what Dr. Holcomb did about history of blood, and my own personal bias, maybe why it's been ignored, and why I think it matters is self-evident, but sometimes even something self-evident, you got to beat people over the head with it, and some other things. Just to let you know, this is where I spent my career. This is, the trauma center is named after my late partner, Eric Munoz, for various reasons by the state of New Jersey, but it's a relatively small hospital, 450 beds. It's underserved population in Newark and the surrounding environs. 4,000 trauma activations, 25% penetrating. And when you look at our data, we're sicker, younger than the national average, but we've been verified, you know, for over 30 years, something the state of New York, except for Westchester Medical Center, you know, found out recently, like, oh, there's something called trauma verification. But we are blessed. Those who provide healthcare, the paramedics, EMTs, firefighters, nurses, PAs, I'm probably leaving somebody out in the audience, and physicians, we are really privileged. We care for trauma patients at probably the lowest part of their life that they never expected to happen when they woke up that morning. And not so much medics and nurses, but doctors, well, you can put in whatever you want in that thing there. And surgeons, you know, really mostly didn't go in to talk to people very well. And I think that that's, you know, that's our own problem. And this is a very famous picture called The Doctor. It was painted around the turn of the century, in about 1900, 1899, something like that. It's from England. And you can see there's you know, there's electricity, obviously, so it's somewhat in the early 1900s. And you can see this little cottage, and there's a very concerned father. And this is, the physician is just, what is he, you know, what is he doing? He's in the moment. But he ain't doing this, right? You know? You know, he ain't doing that, you know? He's just being with the family, because face it, back then, that's about what you did, you know? And we don't do that. And because of that, actually, quite frankly. Manisha, I don't know if you see, there's Vadim. So this is one of my old patients, Mr. Mejia. He had a bad car wreck, ended up losing his leg, and we took care of him in the ICU, and he actually survived Aeromonas hydrophilus sepsis, and actually wrote him up because very few people at all ever survive with this. I think he's like the 1 or 2 survivors. And there he is, 2 years later, and he's all healed up, and he gets around with his one leg faster. You know, and we do prosthesis because it's a hip disarticulation. He gets around faster, and he has 2 little girls that are not so little anymore. And I followed him for a number of years, and there it is. And I've patients who I cared for and followed for a long time seemed to do really better than I thought, or better than maybe they did. And there's another patient, the survivors, please excuse this is, I think, the last gross slide, so don't worry about it. And he has a bad pelvic fracture, and this is Mr. De Sousa. And, oh, by the way, also survivors, there's going to be something very upsetting here, so I apologize ahead of time. And there he is when he goes to rehab, and we get him better. And then Luis, we see him 3 years later, and man, he just looks great with his mom and my partner, Devin Jaria. And then 2 years later, we find out Luis drops dead. Okay, so, you know, if you don't follow patients, you never know what happens to them, right? Well, trauma centers were created to save lives, and we do, and Westchester Medical Center does a bang up, no pun intended, job in doing it, right? But if you don't survive, there are no long-term outcomes, right? I mean, quite frankly, you know, and we are measured, quite often, trauma centers are measured by mortality. I mean, that's just, it's easy to measure, you know, alive, not alive, alive, not alive. And we provide great inpatient care. And actually in America, we provide pretty good episodic inpatient care and emergent care. But we rarely look beyond hospital discharge or even the ED, right? And that's something to our detriment. That's also the detriment to our system. Our healthcare system is broken in so many ways. But this is one of them. Well, this didn't translate very well in one PowerPoint to another, but I'll walk you through why there are arrows and weird little circles there. This was mentioned in Dr. Holcomb's talk. There's the NASM report, or, you know, on trauma systems. 492 pages, 512 pages, I can't remember exactly. It doesn't really matter. All about a military-civilian partnership and trauma care around the country, and there's not one damn word about long-term outcomes of trauma patients in it. Maybe a paragraph, maybe. And this is the chain of care. You can see bystander care, that's like stop the bleed, and then all the EMS people know that's your circle up there, by the way. And then we have inpatient care, that's us, you know, and then early rehab, well, if you have money, and that's a problem. And then recovery and reentry. So, you know, the circle was supposed to be, okay, we got this, sort of, but how do you get to that? I mean, what is, like, you know, is there a miracle? You know, all of a sudden, you know, a magic wand, you know, a fairy comes down and goes, whoop, you know, recovery, you're better. No, you know, there's no, but this book has this thing, but it leaves out the important, what I think is the most important part of the whole deal. And survivorship is modern. You know, trauma centers didn't exist. You know, trauma centers are only a fairly modern invention, quote unquote, from maybe the 70s. ICUs didn't show up until the 60s. I was born before the ICUs. That's because I'm old, right? And really, and you tell medical students that there were no ICUs when you were born. No, you know? And as Dr. Holcomb alluded to in Vietnam, really that was sort of the beginning of critical care because there were no ventilators. No ventilators? Well, yes, they had those iron lung things back in the polio era, but no ventilators, you know? No blood gases. Made ICU rounds really quick because there were none. And our surviving patients, you know, didn't look all that great, right? I mean, Luis, even now, didn't look all that great when he went to rehab, right? He lost, you know, a gazillion pounds and all muscle mass and was really catabolic. And so survivorship is fairly recent. And this is the first, going back a little history, so this is really the first paper I ever found about survivorship. It's written in 1970. It reviewed patients that were treated in the 60s in Birmingham, England. Now, if you've ever been to the UK, Birmingham is not a major metropolis, right? So think about the care that was delivered in post-World War II, Birmingham, right, 1961. Pretty much, but it looks like it could be written today, right? Permanently disabled, under 30, a lot of rehab, heavy need for social workers. Well, this is 50 plus years old and based on 60, you know, 60, 70-year data, right? And basically that was ignored. Paper was written, first injury, ignored. This is some of the first, not the first, but pretty much early on by Troy Holbrook, presented at Western Trauma. I heard her present one of them, and one of them was at AAST back in the 90s, really identifying that PTSD and behavioral health issues impacted recovery. And all of a sudden, now this, behavioral health, right, this was presented in the 90s to surgeons talking about behavioral health and PTSD, and like that went over like a lead balloon. You're like, oh really? Okay, what are we supposed to do about it? We can't cut it open, we can't cut it, we can't sew it, we can't do anything about it. That's not our problem, right? That's not our problem. And so that was, again, great papers by Troy and the group in UCSD, sort of ignored as well. And we keep ignoring this. And then, of course, if you don't find, if the people in Harvard haven't found it, then it doesn't really exist, publish it, then it doesn't really exist, right? And there's a paper by Adil Hader's group, the Forte Project, which, again, all right, fast forward 20 more years, and basically they found nothing different than what Dr. Holbrook and Dave Hoyt found in the 90s, but Harvard found it, so it became important. But you can see, a lot of limitations, a lot of PTSD, and only 60% go back to work or school, right? So not really great. And these weren't all that injured. ISS greater than 9. I think their mean ISS was about 12 in this school, which is basically like a broken leg and a couple of femur, rib fractures. So my colleague, now my partner, my research partner in Australia, who is the true rock star of long-term outcomes, is Belinda Gabby. And they have she runs the Victorian Trauma Registry, and just amazing work she's done, whole body of work, and you'll see some more of it. But they follow people for 3 years post-injury. And again, there's Australia, okay, they drive on the other side of the road and they have kangaroos instead of deers running in front of your car, but still, it's, it's close enough, right? It's America, but upside down. And basically, it's seriously, she found basically that this is, all the stuff. So mobility, you can see nothing really changes in 3 years, right? I mean, there's not a lot that's getting better. Self-care gets even a little worse, a little better. But things, people have pain, people have chronic problems, right? Trauma has created a chronic disease. I mean, that's ultimately what that needs care, right? That needs care. If you have a problem, you need care. So to summarize all this stuff, what we've done with our trauma centers is we've created a lot of survivors because, as articulated by the pediatric trauma talk as well, if you come into this trauma center and you don't have a devastating head injury and you haven't bled to death, you have a 98+% chance of walking out or being wheeled out or surviving out, right? So our success has beget a lot of survivors, right? But they're disabled for a long time, only half return to work or school. There's a huge negative financial impact because it happens to be mostly as a male predominance, and in this country still, men are the primary breadwinners as a population, not in any individual household. A lot of PTSD and depression and anxiety, which affect outcomes. There is an accelerated death rate. I didn't go through that, but if you actually look at Kaplan-Meier curves, there is a subtle, but not so subtle, accelerated death rate from severe injury. No one really understands that. Pain, addiction is real, but the healthcare system is also a pain, right? It's just terrible. And what is trauma center care? What do we do in the trauma center? Why are we so special inpatient? Well, we are the Kumbaya service. We meet you at the door. We cradle you the whole way through the ICU. We hold your hand. Okay, you go to the floor, it's a little scary because we're not holding your hand anymore, right? It's like you're on your own, you know. Okay, it's not quite like going to Dunkin' Donuts, but you know, you're not, you know, but it's like that, right? But you're managed by one service. We tell the neurosurgeons, no, you can't do that. We tell the orthopods, who keep asking, can we fix that? Can we fix that? No, you can't fix that yet, right? We manage everything. And we do everything, and we do this all through your entire hospital stay, and then what happens? Sort of like this. It was a pleasure caring for you. This is a wonderful trauma center. Don't forget to call the clinic. Well, going back to a paper by Belinda, by Dr. Gabby from Australia, they actually spoke to trauma survivors and talked about and discharge was stressful and a lack of coordination of care and no consistent point of contact and long delays. And at best, you saw a junior registrar, okay, like a resident in the clinic, and lack of continuity of care, and it was just abysmal. And this was followed up by another paper by Avery Nathan. So this is Canada, okay? They're good. You know, they prepared people for discharge, some kind of poor communication, surprise discharges, lack of continuity of care, et cetera, perceived pressure to leave. So if we've known for 50 years that people have chronic problems, they have pain, they have difficulties, like we've known this problem existed, right? This is, you know, and we keep rediscovering it because we, you know, like why didn't we do better? Well, one of it's us, right? Trauma surgeons. I mean, we didn't go into this for that per se, but we love when patients come back to the unit. So it's kind of like we're schizophrenic, which is no surprise to anybody who's ever worked with us. There's conscious and unconscious bias. The patients won't return. They won't return. Who is they? You know, a lot of unpack in that word, they won't return. Institutional roadblocks. Let's face it. How many of you, not the trauma survivors, please, how many of you have ever tried to make an appointment in your own clinic? Really? I tell you, I've done this multiple times in my own institution just to see if it changed. No, it's there. I get hung up on, the phone keeps ringing, someone will say, I'll be with you, they never are, right? You know, I've listened to so much bad music. Really, it's terrible. And quite frankly, it was never, you know, I've had an interest in this, but there was no grants. I think Dr. Holcomb spoke about this a little bit. There were no grants. I couldn't get promoted on this. I couldn't become, you know, Wesley J. Howe Professor of Surgery at Rutgers by doing this. I had a lab. I was very successful. One of the saddest days of my life was closing my lab down. But you know, but this is so much more emotionally satisfying for me. But nonetheless, and until I got to the point where I didn't care, I didn't need to advance anymore. So I took this on. Now it's a little better. And then there's some potential financial, as soon as you propose something in a hospital system, they say, it costs too much. It costs too much. So I had to prove that that's not right, and you'll see that in some data. So I was convinced we could do better. So I made it up as I went along, which is what trauma surgeons do best. And we thought we needed to take the kumbaya principle we do inpatient and bring it to the outpatient side. Physical recovery, manage appointments, behavioral health, some pain, addiction, and caregivers. God bless you, right? I mean, you guys are the unsung heroes of trauma recovery, yet no one talks about you at all, right? And so, and there's caregiver, and there's so much burnout, and there's caregiver burnout, and it's talked about by caring for someone with Alzheimer's or someone with cancer or dementia, but not this. It's a real error in judgment. So we created the Center for Trauma Survivorship, and I presented this at Western Trauma back in 2020. It was published, and we'll talk about it. So I took the key from cancer. I stole this kind of phraseology, right? When someone gets injured, the whole family gets injured, right? The family dynamics change. Everything happens you know, and that's a whole issue. And I did something unique. I actually brought in back trauma survivors. And it was kind of hard to hear. We did 3 different groups, about 20 to 30 different people. I can't remember exactly how many. We did these, you know, I had a facilitator. We did those, you know, cloud chart things or whatever it is, mind things. And I just sat and listened to some really hard things, which was good. I was fine with it. And one of the most interesting things was abandonment. I kind of thought, some of it I knew, but abandonment was one of the themes, and I'll see if this resonates with the survivors, but there were 3 stages of abandonment. The first was, okay, I knew, the abandonment from the ICU to the floor. I got that part, okay? But then the abandonment on discharge, and actually the patients who were most ticked off by the whole thing, in some respects, and most vocal, were the ones who actually went to rehab, which we think, maybe erroneously, is a really positive outcome, right? You go into rehab. But rehab completely screwed things up. They never got your appointments right. They never brought you back. They never took care of your wounds. They did, and they felt, and it actually, the survivors said it was another step removed from the trauma center care. And there was a lot of isolation there. Anyway, so we wanted to do everything we could to kind of combat this. So I kind of created a model, and I said, well, we need to take these patients, and we picked severely injured trauma patients. I didn't know if I was going to do this right, but I picked a group that was severely injured. You'll see this. And we created a parallel clinic. So we took the complicated patients, we took them out of the regular trauma clinic, we put them in a specialty clinic in another building, led by a nurse practitioner, Susan, who is amazing and is a survivor, because you'll see in a second, survivor's spouse. I took an old ICU, former ICU nurse. We didn't start with Lona, but I had her being the inpatient liaison. My physiatrist partner saw a lot of the patients. A navigator was everything. I had an early navigator, was Derek, now it's Michael, and they coordinate everything. And then me for moral support and comic relief. It's about what I'm good for. And we had a pet therapist who, unfortunately, you'll see is now, unfortunately, no longer with us, Sam. And that's our group. Susan's the little one there, and Sam's there. And the guy on the right is Al, that's Susan's husband, who's our child life therapist, who was pedestrian struck. And you can see he still uses a cane. He almost died twice in our ICU. And we took care of Al, and he survived, and he's back being a child life therapist. But that's how Susan knew all about being, not to mention she's an awesome nurse practitioner, pediatric hematology nurse practitioner when I took her. But she's clearly knew everything it is about being a trauma survivor's caregiver. And here's Sam. That's how Sam used to hang out in my office, because I had dog cookies. And so I would just feed Sam, and he looks like a resident, right? He's just totally asleep, and but show him food, he wakes right up. It's amazing. He was great with patients, and unfortunately he's passed away since. We're working on another one. This was our patient population. I'm just going to go there. So what did we do? We actually met the patients in the hospital and the family, early on. We could predict who these people were, so it was easy to do. Yes, ISS is on discharge, but we knew how sick you were, and we met several times, Alona and Michael, and sometimes Susan, and sometimes me. And we prepped you for discharge, and we saw you more or less within 30 days of discharge, and we did all this screening, and we managed pain and access, and we helped manage your appointments, and we listened, and we listened. And if you needed care, the best thing is getting to the hospital is also just a pain, right? So we had an Uber health account, because you can't take 3 buses after you have, multiple fractures and this, you don't need it. And the ambulance service is terrible. And so we had an Uber health account, because really what they needed was just cars, right? And we listened. And we made sure you could contact us. So there was a communication. Now, you didn't necessarily get back 1 hour, immediately, but there was a way to contact us if you really needed it. And one best thing about COVID, God bless it, is that telehealth became a reality, and we did a lot of our appointments via telehealth, so it was great. And we didn't have to see people over and over telehealth worked great. And we did include the caregivers, we had caregiver groups, and we got our no-show rate was well below, it's like 15%, it was amazing, right? And because Michael would call everyone, we had contact. How come, you coming? Do you need an Uber help? Do you need the car? Do you need this? And we did this, and this is one of these things, how you keep track of your clinic, and it was great. And this is our population. So more or less, we've served about 500 to 600 patients since we started this, mostly young, again, mostly men. You can see the ages. We started out with 18 to 80 because that was a granting agency. We've expanded that a bit on each end, as you can see. But it's mostly 18 to 80. And, for the trauma people in the world, you can see this is a sick group, right? 93% ended up in the unit. Mean ICU length of stay was 2 weeks, hospital for a month. Half went to rehab, half went home. So they're pretty sick. Underserved population in our corner of the world. And I'm doing some preliminary work because our eligible patients appear less Latinx and less African American than the people who actually show up in the clinic. So I wonder if the clinic also helps break down healthcare disparities. Something I got to tease out the data, but this is who we are. And just to let you know, Newark, we serve a huge underserved population in Newark, Orange, Irvington, the surrounding communities there. About 20 to 25% live below the federal poverty line. 50 are the Alice company, the people who couldn't afford a $400 car repair. It's a population that really needs care, and it's really very rewarding. And this is how our visit goes. Everyone sees Susan. About 2/3 to 80% see Peter, even if he just pops his head in. So we have a physiatrist working with us, and Peter and his new partner. I only see 15 to 20% of people at best, because when Susan calls me to see somebody or talk about pre-operative, and Susan hates when I go to the clinic because I sit and talk to the patients too long, and even though the visits take an hour, it's like I slow the flow of the whole place down, so she do not come anymore, just go away, And we spend time with caregivers, and I have a social worker now, and we do groups, and we do some advocacy, and, the watchword of our clinic is like the bar at closing time. You don't have to go home, but you just can't stay here anymore, And we do behavioral health. But what we're able to do, I hired my own social worker to do counseling. We got 80% of people at least had initial mental health appointment. And as far as physical health is, for those right, getting a physical health appointment is forget it. It's annoying and impossible. But trying to find a behavioral health and mental health professional in this day and age is especially since post-COVID, it's impossible. And I know my sister's actually now one, and she's oversubscribed like that. So the question I had after we've been doing this for a couple of years is, does it matter? Now, making us feel good. It's like chicken soup, it can't hurt, it may help, but does it really matter? Can we actually measure something that matters? Because unfortunately, granting agencies and people who want to give you money want to see a result, whatever that result is. So we wanted to see, does the patient stay in the clinic system? What about ED visits? So we did some pre and post, people who could have gone to the clinic if there was one for the year before, plus the people who we took care of. And we also looked at the financial impact because, that's what everyone's interested in, right? So you'll see this. So this just came out literally yesterday in Annals of Surgery. So is it worth it? This is a little, what's called a visual abstract. So we compared people before and after, and I looked at, and actually, our Center for Trauma Survivorship made money. When I showed this initially, a year before this actually got published, actually a year and a half before this got published, to our CFO, they took all my grant-funded people and put them on hard money. Right now, for those, survivors, that means that they actually, instead of me getting grant money to pay my nurse practitioner, the hospital immediately paid that salary line. So this was a win-win, right? Not only that, we increased clinic visits 400%, and I'll show you, we increased follow-up surgery in the first year 370%. It's huge. So dollars and cents. You have to have a catchy title for a lot of things, Right? And so this is some of the data. You can see here, all surgical clinics, in the pre-group, we had a little bit more patients in the top group, so 145% is the number of patients, so anything over 145% is more than just, can be accounted for by the number of patients we saw, because we saw different numbers of patients, right? And you can see 404 surgical clinics, radiology, rehab, even medicine, because a lot of people didn't have their own physician. Huge numbers. Emergency didn't change, so ER visits didn't change at all, right? So fascinating that we had no impact on emergency visits. We're looking to see what the reason for the visits are. That's a kind of a qualitative thing. But you can see we provided a huge amount more care, right? And we're busy, so it's not like we're seeing patients for no good reason. This is the surgery. And you can see, look at all the hardware removals, revision of fractures, airway procedures, people who had like tracheal stenosis problems and things like that. Cranioplasty, right? Just getting your head put back on if you had your skull taken off by neurosurgery, right? That means you can only imagine that people were walking around who needed subsequent surgery, never got it, right? You can see the ostomy reversals, debridements, hernia repairs, urology, even, vascular reconstructions, a lot of plastic nerve surgery, which is really interesting itself. And you can see we had this is the first year post-discharge, 98 procedures versus 26. And even at 140%, that's something, right? And this is the money part about it, that, it contributed to the bottom line because we kept them in the institution, so they kept coming back, whatever. And this is in a population that is pretty indigent, right? I think this was supposed to be the insurance data, but that's where your insurance data should go, nowhere. So the need is huge. The need is even greater than I thought. And when patients come back, they'll always return. And I think we're on the right track. And our patients and we have great feedback from the patients and caregivers. I mean, they do love us. They love Susan, actually. They could take or leave me, but they love Susan and Alona and Michael and Tom and Peter. But the question is this as good as it gets, right? Have we made patients better? Shameless plug for my 2-year-old grandson, just saying. And recovery is fair. I don't know how to measure it. The more I get into this, and I don't know how to measure this. I think this is an interesting paper from David Spain's group about how, there's body and self and a lot of perceptions of what health is. And I'm not certain you could put a P less than 0.05 on it. I'm not certain you can measure it on a scale. I don't know. The more I get into it, the less I know. The more patients I talk to, the less I understand. And I thought I've been caring for people for 40 years, and I thought I understood a little bit, and I realized I knew nothing. But I've come to the philosophy of some. Some is better than none. Some money is better than no money. Some wine is clearly better than no wine. Some happiness is clearly better than no happiness. And some care beats the hell out of no care. And I'm okay with this. I'm okay with documenting we're providing a lot more care. I'm trying to figure out how to look at actually quality of life around the globe. But I'm okay with what we're doing now. Because the smiles are all what it's about. And these are some of my own patients, you know, over time I've taken care of. That's Logan is a 2-year-old, a 4-year-old. I took care of him as a 2-year-old, and that's above him is a 7-year-old. And Mr. and Mrs. George, who moved to California, and every Father's Day, Christmas, Easter, I get a text message from both of them independently. It's very funny. They're great. I love them. They're Coptic Christian, Egyptian Coptic Christians. They're so sweet. And Mr. Rosario, who lost both his legs, who walks amazingly. I'll leave you with one last success story. This is one of our earlier patients, and I have the permission to show his films. It's a 20-year-old who unfortunately had bilateral traumatic amputations. He was in the hospital a long time. He actually probably had a pre-existing psych and drug use problem before he got injured. And his mother, who was actually her own social worker, had her own issues. We'll just leave it at that. But she was supportive, and we couldn't figure out, you know, he wasn't going to go to rehab, and actually we got on the phone. We really advocated for him. It's one of our better wins. And actually he found the place, and then we got him paid for in Oklahoma at this high-end rehab. Oklahoma. Who would think, right? That's the flyover part. No. Anyway, he's currently on no pain meds, and he sent this 2 years ago, and hopefully it'll play. I'm gonna see. Let's see. Please play. Oh, let's see.
Getting stronger. This is how legends are made. Above it all, untouchable.
Uneven ground going down.
This is how legends are made.
So for those of you, as I see some amputees, going downhill is hard, uneven ground, hard, stairs, especially bilateral, hard, and snowboarding, actually much easier apparently, because he's only as high as the moguls. I don't know. Anyway, he's done great. He sent us some other films, but I really like this one. So, thank you very much.
Questions for Dr. Livingston from anybody in the audience? If not, really just a very inspiring talk, and certainly so appropriate as we talk about recovery and survivorship, because, you know, we can talk about science, and we've talked about a lot of science today, but as Dr. Livingston just reminded us, you know, what we do and is all about the why, and the why is really, you know, sitting in the front 2 rows and far beyond in other places and corners of the country. And we always remember that that is our why, and you are our why. And we can always do it better. And there are ways in which we need to continue to learn from each other and learn from masters such as Dr. Livingston about why it's important to try to do better. And sometimes, I agree, some is better than none. So Dr. Livingston, you know, truly, what an inspiring talk. I think it's just absolutely wonderful. And you know, on behalf of WMC Health, I'd like to present you with this plaque to commemorate your visit with us, and thank you so much. So it's quite fitting, you know, on that note, that we come to, you know, the finale of this symposium, which again is to celebrate and continue to be inspired by our trauma survivors who really, you know, Courage is a very, very tough word because there's so many different ways to display it, and there's so many different ways to describe it. But even being here today to share their stories is a form of courage because it's hard. It's joyous on the one hand to have a reunion with people that were there with them at such a vulnerable point in their life, but it's also takes courage to revisit many of those experiences. And it's, you know, it's so important that we recognize that courage because we benefit from it in healthcare because A, it's a reminder again and to be inspired to the why of what we do, but B, to learn from them and what their experience is like, just like Dr. Livingston was talking about. So here to kind of present the survivors and their families, as well as some awards for some of the EMS work agencies and crews that helped rescue them from the scene. I'll introduce Kate McGuire, our Regional Director of Trauma Services.
Thank you so much, Dr. Prabhakaran. And I'm going to ask if a very special member of our trauma family, Mike McCutcheon, will come up and join me to introduce the first patient. So many of you may remember 2 years ago, Mike McCutcheon actually shared his story with many of us on his story of survival. So it's only fitting that he helps introduce at least our first survivor, Mr. Christopher Malamont. So to our esteemed colleagues and honored guests, it is now my privilege to introduce Christopher Malamont and his family as they come to the stage. On St. Patrick's Day 2023, Christopher's life took an unexpected turn. You can see in the first photo, he's in the crane operating business, and unfortunately he came to our medical center after a devastating construction site injury. The impact was profound as Chris sustained multiple injuries, including, as you can see, a traumatic right leg amputation, a traumatic brain injury, which you can't see because he's doing so well today, multiple facial fractures, great work, bilateral lung contusions, and a fractured pelvis. For 32 days, Christopher fought valiantly in our trauma ICU, enduring multiple surgeries and procedures, including a tracheostomy. His resilience and that of his family never wavered. Today, Christopher continues on the grueling journey, as you can see in some of these photos, in his rehabilitation, determined to reclaim his independence. And I think that far right photo for everyone really shows that as he's working out with another colleague. His steadfast support of the healthcare providers and loved ones overcome the most formidable challenges that he'd faced. So please join me again as I welcome him and his family to share their story.
Hey, how are you guys? I'm Chris Malamont. I just want to say thank you for supporting me. Thank you for coming. And everything's been really good so far. Thank you, though. I appreciate it. And with the doctors and everything, everything's been really good. Thank you, though. I appreciate it, guys.
I just want to thank everybody for allowing us to be here. Just a little bit about Chris. As you've heard, he was an iron worker since 2015. He is my boyfriend of 9 years. This is his mom, sister, and aunt. Unfortunately, a year and 4 months ago, we woke up, said goodbye to each other to go to work, and we got that phone call that there was an accident. He fell 30 feet to the ground, lost his leg, and suffered a brain injury. We're so glad for him to be here today. He's worked tirelessly, nonstop, every day, 5 days a week, fighting to get our lives back. And every day he's shown what it's like to be a survivor. and really make a recovery that is admirable, inspiring to everyone that is a part of his life. And we just want to thank you all so much for everything you've done for us.
We all just want to say thank you to everybody. Everybody knows us. We were here for a long time, and we really appreciate everybody. So thank you.
Our next survivor I was speaking with earlier, I was actually in the trauma bay when he came in, Mr. Eric LeBron. On October 3rd, Eric's life took an unforeseen turn as well. As a motorcyclist involved in a collision, Eric arrived to our Westchester Medical Center in critical condition. Eric's injuries were extensive: a traumatic amputation of his right arm, multiple spinal fractures, rib fractures, left upper extremity fractures, pelvic fractures, an open tib fib, a grade 5 splenic laceration. However, despite these challenges, Eric is thriving, and his spirit remains undetermined. Throughout his 65-day hospital stay, Eric underwent numerous surgeries, received comprehensive medical care. His journey exemplifies not only physical resilience, but also the determination which has confronted his obstacle in each way. I think we can see him cheersing on the boat on the left-hand side, or what is that? You'll have to explain that to me later tonight. Eric's story serves as a proven testament to the resilience of the human spirit, an unwavering commitment of our dedicated medical professionals, as well as that of his family and loved ones. Please join me in welcoming Eric and his family to say a few short words.
Thank you, everybody. There's a lot of people here. This is nerve-wracking, for real. You know, I thought motorcycles were cool, but this is different. This is different. But I just want to say thank you to Westchester for giving me the opportunity to speak. You know, I don't really do that much, but you saved my life, you know.
You're doing great.
Sorry. My bad.
No, you did a great job.
But yeah.
Thank you, Eric.
Thank you for all that you did. Thank you. I appreciate that. I'm sorry.
You did a great job.
I tried.
You did great.
I'm about to pass out now.
You want some more water?
No, I'm okay. Thank you.
Great, thank you, Eric. Unfortunately, in October of 2023, we did have numerous patients come through our medical center. Denise Vasquez. Denise is actually a member of a trauma program adjacent to us and works with Dr. Temperman. Many of you have probably met in this room. Denise's journey began on October 13th, 2023, when she was involved in a car accident that included multiple rollovers, leading her to be transported to Westchester Medical Center. Denise was severely injured with a laceration to her spleen and injuries to her small and large intestines, requiring a laparotomy and intestinal reconstruction. From the very beginning, Denise exhibited remarkable strength and determination. She transitioned from our trauma ICU to the hospital wards with determination to participate in physical therapy and took charge of regaining her strength. I think those flowers probably helped. With unwavering support from her caregivers and the healthcare team, Denise regained her ability to ambulate, tolerate a regular diet, and manage her pain successfully. After 13 days in our hospital, she was able to get discharged home. Denise's journey, again, really shows the resilience of the human spirit. And thank you again, Denise, for joining us today to share a few short words.
Thank you. Good afternoon, everyone. Thank you. I want to say I was excited and really looking forward to coming to formally say thank you. I want to say that I wouldn't imagine that a regular ride home would cause me to go through a lot of pain and suffering due to not great rest and a poor diet. But being at Westchester Medical felt kind of like when I'm at my regular work at Jacoby, where staff went over and above to make sure that not only my physical needs, my emotional needs, and my family was well taken care of. Considering, when you're a wife and a mom, you take care of everything. And working for Dr. Tepperman, I'm used to going at like 200 miles an hour to keep up with him. But they nursed me back to health, and like within 6 weeks, I was back to work, hybrid. And as of April, I've come back to work full-time to kind of do stuff to take care of others who have their times of need. So I want to say thank you all for giving me a second chance to be here for my family and to do something I love. So thank you.
Thank you so much, Denise. Another remarkable young man, Ethan Cruz. Ethan Cruz, it is now my privilege to introduce you along with your amazing family. Suffering on September 28th, of 2022, 18-year-old Ethan arrived to our trauma center following a high-speed head-on collision. Despite being restrained and the deployment of airbags, the severity of the impact left him unconscious and critically injured. Ethan's injuries again were extensive: bilateral pneumothoraces, pulmonary contusions, a burst fracture of his lumbar spine, and a very severe traumatic brain injury. His journey to recovery involved numerous surgeries, including spinal stabilization and a tracheostomy. Throughout it all, his resilience and the tireless support of the amazing family he brings up with him today got him through his darkest days in our trauma ICU. After 26 days in the ICU, Ethan's condition stabilized, and he was eventually discharged to rehab. His story serves as a reminder of the vital role not only of our medical professionals, but that of his family as a support system. Please join me in welcoming Ethan and his family to our stage.
Hello, my name is Ethan Cruz. I'm 20 years old, and on September 27, 2022, I was struck by another driver who was speeding at 80 miles an hour, crossed over onto oncoming traffic, and hit me and two of my best friends head on. And I had internal bleeding and traumatic brain injuries and a spinal injury. Thank God for all the first responders, one of which was a childhood friend. Westchester Medical Center Traumatic Intensive Care Unit was my first stop, and I had 4 surgeries while in a coma and was taken care of for several weeks. Although I was still in a coma, I was able to move to Helen Hayes Hospital. I was there in the beginning, and I woke up in a few months. I had to relearn to swallow, chew, eat, and speak. I went from not moving at all to only moving the right side, and I would lose mobility every time I had a setback. I was in and out of Helen Hayes and back to Westchester Medical Center for 3 shunt surgeries in my brain and many other medical concerns. I have had many angels help me get to where I am today. My recovery has been long, but now my entire body can move. I can walk with a walker. I can read, write, and stand up for long periods of time. Every time someone sees me and knows my story, they call me a miracle. I am working on walking longer, building my memory, and doing more for myself. My family and I are trusting that God will complete what He started, and me and my friends, I'm so grateful to God for keeping me and my friends alive and all He has done, and I'm thankful for my family, Westchester Medical staff, and Helen Hayes Hospital. All of my therapists have been amazing. I am so fortunate that to have a wonderful church family and caring aides throughout time. It takes a good support system to push me through dark times. There's so many people at Westchester Medical Center that I would love to thank, but there's simply too many names. But I will say that trauma intensive care units is the best unit there is. My family and I cannot thank you enough. I do not remember how I was or what happened in the beginning, but I do know that I am better where I am than I once was. I'd like to leave and say two things. One is a Bible verse that my mom always tells me. Be strong and courageous. Do not be afraid. Do not be discouraged. For the Lord, your God, will be with you wherever you go. That's Joshua 1:9. And this is my advice to whatever your journey may be. Keep going. Don't give up. And trust in God. Thank you for having me and being a part of my story.
Amazing job. Thank you so much, Ethan and the Cruz family. I'd also like to bring up to stage Mason Gamble and his family. It is my privilege to introduce you today an extraordinary young man who experienced a life-altering event when he as well was involved in a high-speed head-on collision. However, he was riding his motorcycle on November of 2023. Ejected from his bike and propelled through a car window, he suffered traumatic cardiac arrest on scene. His injuries including bilateral pneumothoraces, traumatic lung injury, rib fractures, and traumatic brain injury. Thanks to Mason's determination and that of his family, he was able to persevere through his most challenging days. Over the course of a 49-day hospital stay, he underwent multiple surgeries and procedures, including to reach his final destination and discharge to rehab. Today, Mason stands before us as a survivor, a beacon of hope and an example of strength of the human spirit. Please join me in a warm welcome for Mason and his family.
Wow, there are a lot of people up there. Hello, how's this going? I'm not used to really talking in front of a big crowd. I got something written down, but I'd rather go off the dome. I'd rather say thank you to the whole first responders that got me out of this situation. If it wasn't for you, I wouldn't be in the shape that I'm in right now. I want to say thank you to all the nurses and everybody who cared for me. If it wasn't for you, in the same regard, I wouldn't be where I'm at right now. This whole experience has been truly humbling. I love to ride motorcycles and do a lot of crazy stuff on motorcycles. And the funny part about the whole situation is I wasn't doing anything crazy at the time of the accident. And that shows a lot because it doesn't matter at the end of the day. You could get hit and no day is guaranteed to come forward. I want to truly say thank you to everybody who helped me. And I got something that's written down, but I think what my mom wrote comes a little bit more from the heart, and I would like her to present that.
Thank you so much for allowing us to be part of today. It is truly special, and Mason's is a little lucky in the sense that he doesn't remember much of what happened. But unfortunately, people up here were there every day beside him. I want to say first and foremost, we learned Mason coded on the scene, and if it wasn't for EMS to stop and bring him back, we wouldn't have him here today. I want to go on to say that the nurses and Dr. Kirsch, I don't know where you are, but I love you from the bottom of my heart. Yeah, Mason had severe lung damage in both of his lungs, and Dr. Kirsch was there every day just telling me, he's young, he'll be fine, he's young, stay strong, he's young. By the second month not speaking to my son, it became harder. You know, I've only went hours without talking to him, and to go what seemed forever was excruciating. Having Jackie and Kathleen to be there and let me cry to them, and having everybody's support was really, I have no words to describe, but thank you. Thank you to everybody who was a part of my son standing here right now. The injuries were extensive, and to know that he's here is everything I can ask for. So I thank everybody who had a part in that immensely. We are eternally grateful.
To end this event, we have one more remarkable young man. His story as well was in October of last year. Joel, a local high school student, was involved in a devastating motor vehicle accident. As a passenger in a ride-share vehicle, he experienced a head-on collision with a garbage truck at high speed. Tragically, the driver of the vehicle did not survive. In the first 24 hours of his care, Joel received over 150 units of blood products to stabilize his condition. His injuries were very extensive, including multiple facial fractures, multifocal traumatic brain injury, bilateral diaphragmatic ruptures, a severe injury to his liver, bilateral hemothoraces, avulsion of his small bowel, destruction of the majority of his colon, and a left femur fracture, along with some lumbar spine burst fractures and a distal ulnar fracture. Joel's care began with an emergency thoracotomy in the ED, and from there he subsequently had numerous surgeries during his hospital stay, which was a remarkable 51 days in our ICU. Fueled by the incredible willpower of the family that's with him today, along with many healthcare providers that are here today, Joel stands before us, a new high school graduate, as you can see on the far right photo. Please join me in welcoming Joel and his family to say a few short words to end our remarkable event today. Thank you again.
Sorry that it took so long. I think we wanted the second round of applause. I'll just get started with what I've written down. I'll always remember the first minute I woke up at Westchester Medical Center. I had no idea where I was, and upon finding out, I had no idea why I was there. I couldn't speak or move my arms, and I hadn't the faintest idea why. Finally, I was able to overhear from a nurse that I'd been in a car accident. A bad one. The drug stopped me from remembering much from the early days, thanks to the amazing Dr. Kirsch and Dr. I don't want to risk it, so I'll just say Dr. P. I don't want to, I'm sorry. I just don't. Dr. Prabhakaran, thank you so much. I didn't want to offend, I'm sorry. And thank you to my amazing trauma and surgery teams. There's a lot from my journey I will never forget. The first stop on my journey of healing was, of course, the hardest. The wounds were fresh, the sodium was low, and the hair, unfortunately, was gone. Physical therapy at that point was standing up and getting in a recliner. And even that amount of pain would bring me close to tears because of my L1 fusion and my broken femur. The inflammation in my forehead had kept my eyes forced open during my 3-week coma, so they were dried out. To maintain my sight in my left eye, it would have to be taped over and covered. Water was a limited resource, since as I had mentioned, my sodium had been very low. However, this also meant I had more cranberry juice than most of you will have in your entire lives. Additionally, my arms had to be restrained because through the fog of narcotics, I allegedly ripped out several IVs and one central line. Before I can continue with my story, I definitely wouldn't be here without my saviors. The trauma surgeons, doctors, nurses, EMTs, and police officers that saved my life that day. So I'd like to, I don't know if I'm authorized, but I'll give them a round of applause. So thanks to them so much. So after my time at Westchester Medical, my next stop was not 2 minutes away at Blythedale Rehabilitation. This was a big step for me as this was my first time walking with a platform walker and without any attachments. However, while I took 2 steps forward, I also took 1 step back. I would feel sick constantly, and after referral to a gastrointestinal specialist from my grandfather in Washington, D.C., I was diagnosed with ultra-short gut syndrome and adhesions obstructing my small intestine. The rest of my journey would be spent in Washington, D.C. I spent about 2 months at HSC, a rehabilitation facility near Children's National Hospital in Washington, D.C., before my final surgery to break down my last obstacle, which were adhesions that were obstructing my small intestine. Once that was done, I only had to spend a few more months in D.C. before I could come home. While I still can't eat whatever I want or walk without some back pain, I am nearing the finish line on this long, arduous journey of mine. I was able to make it to prom and my graduation. I promised my mother I wouldn't let my past affect my future any longer, so I will be going to college on time in the fall, planning to study pre-med so I can help people the same way WMC helped me. Now is the part... Promise, it's almost done. Now is the part of my speech where I tell you all what I've learned from this experience. The first thing that comes to mind is the importance of perseverance and patience. Progress cannot be rushed, and in situations like these, every win is a big one. Next is when working toward a goal, never forget where you started and who helped you get there. I know I'm only able to speak here because of many people in this room. So I just want to thank them once again for everyone, both in healthcare and in my amazing family, for getting me to where I am right now. Additionally, I cannot overstate the vitality of gratitude. Everything in life can, has been, and most likely will be taken for granted by somebody, including me. So take stock of what you have every moment that you have it. Lastly, the final lesson that I learned is that the best way to accomplish any goal, including surviving a traumatic experience and healing, is to have an undying, unbreakable motivation. For me, that is my mother, who never gave up on me for even a second. She left every comfort and routine she had ever known to go with me to every hospital and take care of me every day and night. She is the main reason I've made it this far. Yes, of course, I want to get better for myself. But more than anything, I want to live to be the man worthy of all of her sacrifices, tears, and heartaches. I love you, Mom. And at this point, thank you seems too soft for me, but I'll try. Thank you so much. I promise I'll be the man that you can believe in with every ounce of your being. So, in summation, even though we can't control what happens to us in life, we can control how we react and who we become in the future. I was in a car accident, but I survived, and I will lead a life worth living. Thank you.
Am I allowed a few minutes? Okay. If anything, just throw me off the podium if I overstay my welcome.
The end of Joel's speech was a big secret. I was not allowed to hear any of it, and thank you, Joel. I love you. We never felt like a sacrifice. It was very natural to help take care of you and get you to where you are today. In a nutshell, just want to share a few of the insights that came up to me around Joel's accident. October 30th, police officers called me. I was taking care of my grandmother on Mondays for a few hours in between home health aides, and I get a phone call, and I was traveling back from Brooklyn to Westchester, and they said, we have an ongoing investigation. Are you home? We need to talk to you. And I thought it was so weird, so I kept calling my husband. He came out. I asked him to keep the phone on. And then I overhear them saying, your son was in a car accident. They couldn't tell me because I was driving, stuck in traffic. And so my husband rushed. I called Joel's siblings. I called Joel's father so we could all meet at this hospital I've never heard of. I'm originally from Ukraine, then Brooklyn, then Westchester, and so I've never heard of Westchester Medical. I was just stuck in this horrible traffic, and I kept begging people to let me go, and they did. It was miraculous how cars would just, spread apart to let me go. I kept saying, my child is in a hospital, please let me go, and everyone did. And I got there, I just dropped my car, and Doug met me, and I felt like my legs would give out, so I asked him if I could hold his hand. I don't know if he's here, and he just grabbed my hand and took me to where Joel was still in the operating room, and then I see hands handing over Joel's clothes, and I'm like thinking, why are they giving me his clothes? And there were sneakers and one of the iPads with the case, his socks, and I look at the sneakers and the shoelaces were cut, and I'm like, why are they cut? I had no idea what happened. I never Googled what happened, and so I put in one of the AirPods in, and I was talking to Joel. I was like, you gotta live. You got to live. We love you. We need you. The world needs you. I was talking to him. I'll call it losing my mind or coping. Joel was in induced coma, and just want to share something with you. I was questioning everything, and in those first couple of days, I was questioning God. I was praying, and I was really angry at God. Why? How could He let this happen to my child? He's such a good kid, and he didn't do anything wrong. And then I had this understanding. Something came to me as I was asking all these questions, that somebody made a bad choice, and Joel was saved, and people kept coming up to me, doctors, nurses. It was a miracle that Joel survived, and I was thinking, what does miracle mean to me? And what it meant to me is this godlike force, power, that literally grabs a person out of the hands of death, and this godlike force is very loving, very caring, and very kind. And so I asked this force, this God, if He could give me a sign that He was there for Joel. I needed to know that this force of love and care was there with Joel, and yes, to find Penny. And the next day I found a Penny in the emergency room. 2 days later, I went to look at the car because I kept a diary for Joel, and it looked like a shredded paper, completely everything misplaced except for where Joel was sitting. And then I looked down, and right in front of his seat, I found a penny. And that's how I knew that God was there with Joel. Fast forward, Dr. Kirsch
came by to visit Joel like he regularly did. And I was complaining to him that, you know, when Joel woke up from the coma, Neuro would come in and give Joel all these commands to perform. Show me 2 fingers, show me 3, give me thumbs up. And Joel never followed any commands, but as soon as Neuro leaves, he follows all of the commands that I give him. And Dr. Kirsch is listening. He's like, really? I said, yeah. And I'm like, how would they would put in their notes that Joel cannot do anything, and yet he could do so much. And Dr. Kirsch was facing his back to Joel. Joel was in his bed, and he's like, Joel, give me 2 fingers. And Joel's like, you know, give me thumbs up. And Joel's like, Dr. Kirsch. And so he saw, and that's when it hit me. I was so busy feeling God and looking for God and God-like force that saved Joel. And I was outside of Joel's room. I kept looking on the floor, looking for pennies. And then when I looked up and I saw Dr. Kirsch, I realized that God was in this incredible surgeon. God was in Dr. Prabhakaran. God was in every nurse. Mary, Kathleen, Carla. I don't remember most names, but I remember every one of your faces. People that brought food for Joel, cleaning his room. You all have God in you, in my world, and I love you all, and I'm so grateful. Every time I hug my child, I think of you. Every time I look in my child's eyes and hear his voice, I think of you. I pray for you. I pray for your families. I know it's your job, but what you bring in is so much care and love, and that's why our survivors are here with us. I love you. I'm grateful. Thank you. Thank you, Joel. I love you.
Hi, I'm just going to take another minute. I'm Joel's father. I just want to thank everyone here for bringing our son back. I just want to share, we met the EMTs sometime, a couple of weeks, I think, after Joel's accident. And we had a conversation, I think, with 4 of them out of 7 or 8 that actually saved Joel. And that's when we learned how it all happened. That's when we learned that the first person at the scene, and I'm sorry, I'm bad with names and I don't remember everyone's name, but the first person was on his way home. He was off the clock and he was just passing by and had his radio on, and he heard about Joel's accident, and he turned around and he went back to save our son. And then the rest of the crew showed up and they literally saved him and they rushed him. And that's when we learned about the 1-hour rule, that if they weren't able to get him to the hospital within an hour, Joel wouldn't be here today. So thank you so much to all the EMTs. Thank you to all of the doctors at Westchester Medical, Dr. Kirsch, Dr. Prabhakaran. Again, I don't remember everyone's name, but thank you. Not only doctors, every member of the staff, every nurse, every PA, every nurse's aide, maintenance crew, everyone, you all do your part in making sure that boys and girls, boys like Joel, survive. And thank you.
I'm going to have you stay on the stage. At this time, I'm actually going to ask if all of our survivors that spoke today and their families can come back on the stage and join us. That was a great segue, unprompted, because I'm also going to ask Dr. Kakuza and Mark Musicus for our EMS. We have a little bit of something for you all today. So please, all survivors, join the stage.
I saw, recognized him.
All right. All right. I always have the hardest time coming up here after all of that and crying for the last 20 minutes, so excuse me. We'd love to welcome up the EMS crews that brought each of our survivors in and offer them a little appreciation, outstanding service award. For the first survivor, Chris, Hawthorne EMS and WEMS EMS. The crews are here: Harold, Jerry, Mike, Joe, Christina from Hawthorne EMS, and from WEMS, Briona, Hamlet, and Alyssa. If you are here, please come on up. What's that? Hi.
That's all right.
We'll sort them all out. And please stay up after you receive your award. The second survivor, Eric, Empress and LifeNet were the EMS and flight team that brought you to Westchester Medical Center. Kevin and Chris from LifeNet, and Justin and Sani, if you're here from Empress, please come on up. Yeah, give it back. Right. I'm still back here, I promise. Our third survivor, Denise, also Empress and LifeNet, but a couple different crews, I believe. So from LifeNet, Dan, Nick, Steve, and Chad, and from Empress, Alex, Peter, and Angela, if you are here. Please come on up. Our fourth crew, who brought Ethan to Westchester Medical Center from Ambulance, we have James, Neil, and Megan. If you are here, please come. And the crews that brought Mason here from New Windsor EMS, as well as Hackensack Flight Team. Michael and, Zach and Tom should be here from Hackensack, and I believe Michael from New Windsor hopefully is with us.
Thank you so much.
Oh. Come on over. And lastly, certainly not least, Joel. I believe you may have already been introduced, but Somers EMS and again WEMS. John, Rocco, Brendan, Isabella, Sean, and Dave. If you are here in the audience, please come on up. I literally can't see what's going on, but with that, I bet we give everyone up on stage a huge round of applause. Yeah. And please, we want to give plenty of time for EMS and the families to talk and whatnot. But before we do that, if Dr. Prabhakaran and Kate want to come back to the stage. Again, I don't know where you are. I forgot my step stool. I left it in the trauma bay.
I think that there are no concluding remarks that could top the stories that we just heard. So I'm going to let those voices speak for all of us when I say thank you for coming and thank you for your partnership for the patients, their families, and EMS. Please do spend this time, reuniting with one another and sharing this wonderful bond. So thank you for everybody for today.
Mark's gonna harass me if I don't remind you about CMEs, so I don't, CMEs are out front, we're gonna do some photo ops, please hang out and speak to each other, and thanks again, we look forward to it next year.
CMEs and CNE and the eval forms all out front. Thank you, guys.